Yeah, everybody.
Right, we are live, ready. Chahal, go please.
Hi, Arvind. Good morning. We welcome you to the second day of our virtual ASSICON. We begin with the VTI Gold Medal free paper session. I invite our moderators, our founder, president, Dr. VT Ingelhalikar and Professor Arvind Jaiswal. We begin with the first speaker. Uh, I call upon Dr. Ayush Sharma. He'll be speaking on prospective randomized control pilot study to compare the role of cerebrolysin in operated cases of degenerative cervical myelopathy. Dr. Ayush, please.
A warm good morning to all of you. We are presenting our pilot study on prospective randomized study to compare the role of injection cerebrolysin in operated cases of degenerative cervical myelopathy. Cervical spondylosis stands for a degenerative pathology which leads to reduction in the spine canal diameter, which in turn causes compression on the spine cord, which results in cascade of symptoms collectively termed as degenerative cervical myelopathy. Now, the current literature has refocused on the neuroinflammatory pathway which are associated with cervical myelopathy. Presently, the efforts are underway to evaluate the efficacy of surgery combined with neuroprotective agents to give the best possible post-operative outcome in these patients. And this is where the role of cerebrolysin comes into picture because of its various neuroprotective actions. Let's start with understanding what is cerebrolysin. Cerebrolysin is acquired by enzymatic degeneration of fat-free pig brain. It has neuroprotective, neurotropic, and neurodegenerative properties. It contains various growth factors like brain-derived neurotropic factors, insulin-like growth factors, and nerve growth factors. It has already been extensively researched with variable success in other neurodegenerative conditions like Alzheimer's, Parkinson's disease, etc. This is the only study published till date which has studied the role of cerebrolysin in cervical myelopathy, but this study was done for conservatively managed cases. Ours is the first pilot study ever to study the role of cerebrolysin in operated cases of cervical myelopathy. Ours is a prospective, randomized, double-blinded control trial. We had 60 patients who were randomly divided into two groups of 30 each. All the patients were operated by the same team of surgeons. The patient and the assessors both were blinded to the management given. The first group was given injection cerebrolysin 5 ml for 30 minutes over a period of 21 days. The second group was administered placebo for exactly the same duration. Data was collected by independent observer preoperatively and postoperatively at 1 month, 3 months, 6 months, and 1 year. The assessors included clinical, radiological, and functional outcomes. When it came to result, both the groups were comparable to each other when it came to the age, preoperative duration of symptom, and the demographics. In our study, 30 of the patients were operated by the anterior approach. We used posterior approach for 29 cases, and in one patient, we used the combined anterior plus posterior approach. In terms of VAS score, both the group has preoperatively comparable VAS score. In postoperatively, the cerebrolysin group showed better improvement in VAS score compared to the placebo group, but this difference was statistically not significant. Similarly, when we evaluated the MGO scores, both the groups were comparable preoperatively with better outcome in terms of MGO score for cerebrolizine group. But again, this difference in improvement was not statistically significant. Cerebrolizine group showed significantly better hand function at 1 year follow-up. Even post-operatively, the neurological recovery was better for the cerebrolizine group, with 66.7% of the patient showing complete neurological recovery compared to 56.7% in the placebo group. Even when it came to evaluating the post-operative MRI at 1 year follow-up, the cerebrolizine group showed better recovery of signal changes with sometimes complete reversal of the cord changes at 1 year follow-up MRI. Cerebrolizine has been studied extensively in randomized double-blinded placebo trial for Alzheimer and dementia, where it has shown good promising results. Alam et al. Found that cerebrolizine given over 4 weeks was safe and effective, and they reported no neurological deterioration at 6 months follow-up in cases treated conservatively of cervical myelopathy. In our study, we found that cerebrolizine group showed significant improvement in hand function at 1 year follow-up compared to the placebo group. Even the neurological recovery was better in the cerebrolizine group compared to the placebo group. Alam et al. Study showed some minor side effect of cerebrolizine, which resolved at 1 week. In our study, we didn't find any adverse reaction to the drug. Our study does have its limitation. It is single center experience. It has a relatively small size. It has a long duration of drug intervention, which was 21 days. So based on our study, we conclude that use of cerebrolizine in post-operative cases of cervical myelopathy is safe. It can result in improved neurological recovery, especially the hand function. We have already commenced a study on a 10-day drug schedule, and the initial results should be available by end of 2021. Further studies on cerebrolizine in other spine pathology, including dorsal myelopathy, spinal cord injury, will further establish its efficacy as a neuroprotective agent in spine pathology. Thank you. Thank you so much.
Yeah. Thank you, Ayush. And the paper is now ready for questions. We have 3 minutes, sir. Dr. Arvind, sir.
Yeah. Can I ask the first question, Dr. Arvind?
Go ahead.
Yeah, Ayush, congratulations for this wonderful study. I was recently involved in randomizing protocols, and anything in the cervical spine, especially in cervical myelopathy, which has lots of other effects like duration, multi-segment or monosegmental, presence of instability, what is the cord diameter, space available for the cord, pincer effect, so many variables, diabetes, Parkinsonism. How did you try to come to a conclusion with just 30 cases on each side? They say a minimum of 390 cases are necessary even to find a minimal effect. 30 seems to be too low when it's so multifactorial.
Yes, sir. So I agree with you, sir, and that's why we have this is just a pilot study, which is part of a broader study, because this has never been tried in post-operative cases. So even the safety margins are unknown. So what we did is the groups, whatever groups we had was comparable. The biggest problem with the study is if you have to give a drug for 21 days, this is based on the set protocol for the drug, which I cannot change. All the studies have recommended that. So as you understand, enrolling patients for 21 days post-observation study is very, very difficult. To get 300 patients will be out of question. So this was the pilot study, which is mainly to see the side effects and the safety study. And based on this, as we already said, we're doing a much larger study, which can really focus on the result in terms of the various matched demographics and everything, which you really pointed out.
Ankur, you said there were changes in the post-operatively. There are changes in the cord signal also.
Yes, sir.
Did you by any chance study how long these changes existed prior to the time?
No, sir, we
Because
didn't.
signal improvement is not a very usual outcome
Yeah.
of cervical myelopathic decompression.
Yeah. So we didn't study how long this started. We used a pre-operative MRI and we used the ISI grading. I couldn't put all the result because the constraint in time. And the same reviewer, same radiologist who did the pre-op and post-op, he compared the ISI score, which is the single intensity score, pre-operative and post-operative. And he graded each and every MRI and looked at the signal reversal. We got a better signal reversal, even the post-operative signal reversal 1 year in the patient where we gave the cerebralizing group compared to the placebo group.
If you manipulate the image, manipulate not decidedly, accidentally also, with brightness and contrast, these changes do look different. Something which is not apparent becomes apparent. Something which is apparent doesn't become apparent now. Those factors also must be taken into consideration before we making a statement that the changes are reversed.
Yeah, so I agree with you, sir. So that's why we use the same center. All the MRI was done at the same center. It was the same radiologist who graded all of them.
Okay.
So that way we still could be some observation variation, but we have tried to negate it as best as possible.
Thank you, Ayush. That was a good presentation. So we move on to the next paper, please.
Yeah. I call upon Dilip Chand Raja to present his paper on why do modic changes result in poor clinical outcomes.
Respected chairpersons, honorable judges and dear colleagues, a very good morning to all of you. My topic is why do modic changes result in poor clinical outcomes? Novel insights from proteomic analysis of lumbar disc with modic changes. Modic changes represent subchondral bone marrow changes adjacent to degenerative disc, first described by Roos et al. And later classified by Modic et al. The etiology could be mechanical, inflammatory, and even bacterial subclinical infection. The last decade has witnessed a large number of studies equating modic changes to low-grade subclinical infection. And recently, more studies are coming out with poor clinical outcomes following surgical infection in modic changes. With this background, the aim of the study was to investigate the pathological activity which could cause unsatisfactory outcomes in lumbar herniated disc with modic changes, to identify potential targets for molecular therapy, and to analyze the possible role of infection. We performed a prospective cohort study and experimental analysis using consecutive patients undergoing microdiscectomy procedure at Ganga Hospital from April 2018 to December 2019. 309 patients underwent microdiscectomy, 86 patients belonged to the Modic group and 223 belonged to the NMC group, among which 18 consented to the MC for further proteomic analysis and 15 consented in the NMC group. Following quality check, we included 14 in the MC group and 10 in the NMC group for proteomic analysis and validated it further by quantitation of amino acids. We employed a standard proteomic workflow. The results are being presented in three criteria: the clinical and functional outcomes, proteomic analysis, and validation of amino acids. There was no significant difference between the two groups in BOS score for leg pain. However, there was a difference in ODI scores, with the MC group faring poorer when compared to the NMC group. Similarly, patients had a poorer McNabb patient satisfaction criteria at 1 year when compared to non-Modic group, and a higher rate of surgical site infection in Modic changes. After applying stringent filters in the proteomic analysis, we identified 208 proteins in Modic changes and 193 in non-Modic change group respectively. 45 were found to be specific, whereas 30 were found to be specific in the non-Modic group. Among the 163 differentially expressed proteins, 66 were found to have a more than log 2-fold variation and 14 were found to be statistically significant. Looking at the downregulated proteins in the Modic change group, components of extracellular matrix such as collagens and proteoglycans were downregulated, in addition to proteins essential to control infection and regulators of inflammation and central component complement system. Looking at the upregulated proteins in Modic changes, they mainly involved acute phase reactants produced in response to trauma or infection, immune system responses to antigenic exposure, and cytoprotective proteins in response to inflammation. We compared the biological pathways between the two groups using reactive database, where it identified infection-mediated immune-influenced pathways and immune-responsive pathways only in the Modic changes group. More importantly, we identified immunoglobulin-mediated phagocytosis in the modic change group, and more number of proteins were identified to participate in this pathway in the MC group. To analyze the bacterial role in modic changes, we identified the host defense proteins between the MC and the NMC group. First, we built a database comprising 263 well-established HRDPs which were manually curated from a detailed review of literature and compared between the two groups. This picture is a heat map which clearly shows the intensity of green light higher in the modic changes when compared to the non-modic changes, which in turn indicates an active host defense response in the modic changes group. 14 were found to be specifically expressed in the modic change, whereas only 2 were found to be expressed specifically to the non-modic change group. Looking at the interactive network analysis of specific proteins in modic change and non-modic change group, we found a statistically significant association with different number of proteins such as ubiquitin, proteasome, and glutamic acid in the modic changes, whereas such an association was not found between the non-modic change proteins. This analysis further confirmed by amino acid quantification method using high performance liquid chromatographic analysis. We analyzed 18 amino acids. This is a typical picture which we get following amino acid analysis of each sample. And our hypothesis of excessive glutamic acid was confirmed by amino acid quantification in the modic change group. Coming to discussion. Recently, we established that preoperative modic changes are independent risk factors for surgical site infection, raising doubts whether they could be latent or subclinical infections. In this study, we performed a clinical and functional outcome following microdiscectomy, and a subset of preserved disc of the MC group were compared to the NMC group at molecular level to understand the reasons for poor outcomes. Our study clearly established the activation of innate and adaptive immunity, inflammation, and leading to low-grade discitis in modic change group. More importantly, we identified the ubiquitin-mediated degradation pathway in the modic change group, which could lead to excessive extracellular matrix breakdown and accumulation of glutamic acid in the modic changes. Looking at the role of glutamate in low back pain, we know that neoinnervation secondary to secretion of neurotropic factors is very common in degenerative disc disease, and glutamate, being an excitatory neurotransmitter, could sensitize these nerve endings and cause excessive pain in modic changes. So this gives molecular targets to improve outcomes in modic changes. It could be inhibition of ubiquitin-mediated proteasome degradation or even anti-glutaminergic therapy in modic changes. To summarize the results, our study provides novel insights into pathomechanisms of modic changes where chronic bacterial exposure could lead to host defense response mechanisms, uncontrolled inflammaging, ubiquitin-mediated proteasome degradation pathway, and glutamate production, which could in turn cause poor clinical outcomes. The clinical significance of this study is it could be addressed by administering antibiotics or probiotics at the higher level, or address inflammaging by TNF-alpha blockers, or produce monoclonal antibodies against the ubiquitin-mediated proteasome degradation pathway specific to modic changes, or even try anti-glutaminergic therapy against glutamate production in modic changes to improve clinical outcomes. Thank you.
Thank you. That was a good paper. Any questions?
Dr. Gautam has a question. Yeah, please go ahead, sir.
Yeah, I had a very nice paper, very comprehensively worked up. But my question is that across the groups of modic changes, what was it all that the discectomies were done in modic type 1 or modic type 2 or 3? Was the result different across the modic groups? That is the first question. And second is, as a corollary to your paper, does it mean that every patient who has modic changes and in whom we do a discectomy, we should send up the disc or the material for histopathology, microbiology, and start them on antibiotics in the long term for about 3 to 4 weeks?
Thank you, Gautam sir, for both of the questions. First, answering to the question number 1, this study involved mainly modic changes type 2. It is very difficult to find a modic change of type 1. Modic 3 is even more rare. In this, only one patient had modic type 1 change. In the previous study of our European Spine Journal publication also, where we've identified modic changes as independent risk factor for SSI, most of them were even modic type 2. Now, this is in contradiction to a previous statement by initial investigators that only modic type 1 is inflammatory. We are recently finding evidence that even modic type 2 could be a subset of clinically subclinical infection. For the question number 2, we all know that it is very difficult to get a culture biopsy even in well-established infections like tuberculosis or pyogenic spondylodiscitis. This is because we use only a very standard culture media, which we don't know whether the bacteria would grow or not. So the entire world is looking on advanced DNA-based detection techniques like a multiplex PCR, which will give and analyze results for 64 bacteria together, or even higher, we can go for metagenomic sequencing, which over the years will be the solution, because the rates currently is very high per sample. So maybe in future, over repeated usage, the price may come down. So looking at the higher incidence of surgical site infection and poor outcomes in these patients, we don't find any reason why a biopsy should not be done in all these patients with modic changes.
Can we have one quick question before we pass on to the next?
Can I
a brief answer, please?
Can I, Dilip? My question is, what is the message to the clinician with the modic changes when we operate?
The message is that these subset of patients should be carefully, prospectively followed up over a period of interval, and any sign of infection like fever or more pain during the follow-up should be investigated appropriately, and if possibly identified, addressed at the earliest possible time. And also a counseling that these modic changes could represent these inflammatory signals should be given, a message should be given to the patients.
Thank you, Dilip. That was an excellent presentation. So we move on to the next presentation. The presenter is Siddharth Gupta, please.
Hello everyone, my name is Dr. Siddharth Gupta. The title of my paper presentation is Correlation between Quantitative MRI Parameters with the Clinical Scoring System in Degenerative Lumbar Spinal Stenosis. Incidence of lumbar spinal stenosis is around 5 per 100,000 with an ever-increasing prevalence in the Indian population. Back pain, leg pain, neurogenic claudication, and sometimes neurological deficit are the major symptoms. Numerous clinical scores are available for assessing the severity of this disease. Several quantitative MRI parameters have been described for the diagnosis. Few studies have compared the clinical scores and MRI parameters, but they have found no correlation. This study attempts to establish a correlation between 10 commonly used clinical scores and 8 quantitative MRI parameters for the degenerative lumbar spinal stenosis. It was an observation study done at Maulana Azad Medical College from September 2018 to Jan 2020. We took 82 patients aged more than 40 years with a mean of 53.02 plus minus 9.18 years. Females were more than males. Most common level involved was L4, L5, and it was a multi-level disease. We enrolled 174 patients, out of which 82 were recruited for the study. They had the symptoms of neurogenic claudication with or without radicular pain and MRI-proven degenerative lumbar spinal stenosis. 92 patients were excluded. They were having primary canal stenosis, including achondroplasia or congenital spine anomalies, any prior lumbar spine surgery, polyneuropathy, osteoporosis with kyphotic deformity or a vertebral collapse, and proven vascular claudication. For each patient, the following scoring systems were used and the performa was filled by the patient. We used Oswestry Disability Index, Spinal Stenosis Questionnaire, Quebec Pain Disability Scale, Visual Analog Scale, Modified Japanese Orthopaedic Association Scale, Pain Disability Index, Cell-Paged Walking Test, Euro Quality of Life 5-dimension score, Neurogenic Claudication Outcome Score, and the SF36 scale. MRI files were uploaded on the Radiant Diacom viewer and measurements were done at the maximum stenosis level at the level of the disc. Following 8 MRI parameters were measured as described in the literature. Here in the figure 1, we can see that 1 represents the AP diameter of the spinal canal, 2 is the ligamentous interfacial distance, 3 is the lateral recess height, and 4 is the lateral recess angle. In the figure 2, we have measured the cross-sectional area. In the figure 3, 1 represents the AP diameter of dural sac and 2 represents the transverse diameter of the spinal canal. And in figure 4, we can see how we have measured the mid-sagittal diameter of the spinal canal. Data entry was done and statistical analysis was done. P-value of less than 0.05 was considered as statistically significant. R value more than or equal to 0.7 was considered a strong correlation, 0.7 to 0.3 as moderate, and less than 0.3 as a weak correlation. This table shows the clinical scores and the mean, median, standard values of all the clinical scores. These are the SF36 components. This table shows the MRI parameters and their mean, median values of all of them. In this table, we have correlated the MRI parameters with the clinical scoring system. This green shading represents the strong correlation between neurogenic claudication outcome score and transverse diameter of the dural sac. And yellow ones represent the moderate correlation between MRI parameters and the scores. In this table, we have correlated the SF36 components with MRI parameters. They have mostly shown only a moderate to weak correlation. So several clinical scores and MRI parameters have been used, but no consensus on the best parameter exists till date. We have found a moderate negative correlation of VAS scale and ODI scale with the mid-sagittal diameter and lateral stress parameters, and none with AP diameter and cross-sectional area, just like in previous studies. No studies have correlated the cubic scale or pin disability scale with the MRI. In our study, a moderate negative correlation was found between cubic scale and mid-sagittal diameter and between pin disability index and cross-sectional area. Just like in our study, multiple authors have evaluated MRI for correlation with claudication distance and MJOA scale, but did not find any. Neurogenic claudication outcome scale had a strong to moderate correlation with the maximum MRI parameters, that is 5 out of 8. It had a strong positive correlation with transverse diameter of the spinal canal and a moderate positive correlation with the other 4 parameters. In our study, self-paced walking test, modified Japanese Orthopaedic Association scale, cubic scale, pin disability scale, SF36, and Swiss spinal stenosis questionnaire did not show any significant moderate to strong correlation with the MRI. Limitations. First of all, we have utilized the supine MRI. Some studies have shown that standing MRI may better recreate the spinal stenosis condition due to axial loading. And being a disorder of the elderly and hence comorbidities, polypharmacy, and other degenerative disorder of the lower limbs may have as a confounding factors. Strength of our study is that this is an elaborate study which correlates 10 clinical scores with 8 quantitative MRI parameters of lumbar spinal stenosis. Conclusion: neurogenic claudication outcome scale has an elaborate coverage of all the clinical presentation of lumbar spinal stenosis and was found to have maximum, that is 5 out of 8 correlation with MRI parameters. Hence, it can be considered the best score for our population. In the future, we would like to correlate the neurogenic claudication outcome scale with the surgical outcomes with a larger sample size. Thank you so much.
Thank you, Dr. Gupta. Can we have a few questions, if there are any from the floor?
Yeah. Dr. Gupta,
Yes, sir. Good morning, sir.
count any dynamic element like any instability, hypermobility, collapsing and opening of a disc? Because this dynamic change
hello, sir. Actually,
difference to the
yes, sir. Yes, sir. But we have only taken the MR in the supine position, and we have not done it in the standing or any movements. So only in the supine position we have done the MRI. So
because a lot of these patients do have hypermobility, which compromises more than lying down position.
You are right, sir. And limitation is that only, sir, that only the MR in the supine condition is we have done. Yes, sir.
Another quick question, please.
Yeah. Siddharth, did you get any chance to compare with few stress MRI? Because stress MRI will certainly give you sort of loading standing images.
Yes, in the stress MRI, the axial loading is more, but in our hospital, we had only the MRI in the supine condition only. So we were unable to get it done in the standing condition.
Dr. Gupta, can I ask you, what is the clinical relevance of this study? Because clinically, none of us are going to operate because the transverse diameter or the AP diameter is low. We always go by clinical symptoms and then look at the MRI to find out the level and the etiology, isn't it? Individual MRI parameters of the canal doesn't have much relationship or relevance to our clinical decisions. So what is the importance of the individual radiological parameters?
Yes, sir, you're right, sir. The NCOS scale had the maximum correlation, and it has a strong coverage of all the clinical scores also, and it has the all the major symptoms are also covered in that score. So we can use NCOS scale and we can grade the severity of the patient's position. So
one last quick question,
as a yes.
if there's any. Okay, I think we'll just move on to the next paper, and that is by, thank you, Dr. Gupta. Next paper is by Dr. Kalyan Verma.
Good morning, everyone. I'm going to present my research on whether the time has come now to distinguish between ligamentum flavum buckling and hypertrophy in cervical myelopathy and analysis of factors influencing them. So many of us have come across this type of MRI or this type. If you can notice, on the flexion, there is no ligamentum flavum thickening, whereas on extension, you can identify ligamentum flavum thickening. This is definitely not hypertrophy. Hypertrophy is something which is static, whereas this has changed with position. So this is a dynamic variable, which we call as ligamentum flavum buckling. Ligamentum flavum buckling is not synonymous with hypertrophy. So ligamentum flavum hypertrophy is static, whereas buckling is dynamic. And buckling can be revealed using a dynamic MRI. So is buckling pathological? As you can see, in a normal individual on flexion and extension, there would be no buckling. Also in the MRI here, you can see that there is a congenital anomaly at C5-6 and at C6-7 level, you can identify buckling, whereas there is no buckling at the adjacent levels. This suggests that buckling doesn't happen at normal cervical levels, nor does it happen in normal individuals. So it is definitely pathological. Now, what is normal? In normal individuals, ligamentum flavum buckling is composed of 80% of elastic fibers and 20% of collagen fibers. These elastic fibers prevent it from buckling into the vertebral canal with neck movements. So what is the rationale of our study? So till now, the literature has not distinguished this hypertrophy and buckling when addressing cervical myelopathy. Also, the factors causing the ligamentum flavum buckling into the spinal canal are still unclear. So we aim to investigate the relationship between dynamic ligamentum flavum buckling or static ligamentum flavum hypertrophy and intervertebral instability or disc height in the cervical spine. So we did a retrospective analysis of our hospital records and imaging database from Jan 2014 to Jan 2020, and 2 independent spine surgeons performed the measurements. The inclusion criteria included a patient with a documented diagnosis of cervical spondylotic myelopathy with MRI findings supporting the diagnosis and with neutral adequate flexion and extension X-rays and MRI available on our imaging database. Patients with documented diagnosis of myelopathy due to other causes and those with no evidence of spinal cord compression were excluded from our analysis. So what did we consider as an adequate X-ray or MRI? Only when the X-ray or MRI has occiput to superior end plate of T1 visible and 30 degrees of movement from the neutral was possible in either films. How did we measure instability? Instability was defined as translation greater than 3.5 mm or 20% or rotation greater than 12 degrees on dynamic images. We measured the disc height at the center of each disc by measuring the distance between the adjacent end plates. Ligamentum flavum thickness was measured using 2 lines. A line A measuring the posterior border of the disc space to the base of the spinous process, and line B measuring the posterior border of the disc space to the posterior border of the spinal canal, and the difference between A and B is considered as ligamentum flavum thickness. The difference in the thickness between flexion and extension films is considered as ligamentum flavum buckling. On screening of in-hospital records, we found 445 patients who on preliminary selection, whereas using the eligibility criteria, we finally included 169 patients in our study, thus making up to 1,014 levels for measurements. The mean age of patients included in our study was 59.5 years. The entire sample size was divided into 2 groups based on the presence or absence of ligamentum flavum buckling. Those with buckling of greater than 1 mm was considered as buckling to account for measurement errors, and the 1 mm was taken based on the Uden's index using the ROC curves. 798 levels had buckling, and 216 levels had no buckling in our sample. Out of these 798 levels with buckling, 117 levels satisfied the criteria for instability, whereas 681 levels did not satisfy. Based on the statistical analysis using Fisher-Exact, we found significant association between intervertebral instability and ligamentum flavum buckling. However, the ligamentum flavum hypertrophy was not found to be significantly associated with instability. Using Pearson correlation coefficient, there was no correlation between buckling and age. Similarly, no correlation was found between gender and buckling. Also, there is no correlation between age and ligamentum flavum hypertrophy. Also, the disc height also had no correlation with ligamentum flavum buckling. So, based on our results, we hypothesize, as you can see here, this is the stress strain curve of any ligament. Beyond a point called the yield point, the ligament permanently deforms. And this is the elastic region wherein which after stretch, the ligament comes back to its normal size. After the point called yield point, the ligament permanently deforms, and beyond a point called failure point, the ligament fails to function. In cases of intervertebral instability, as the distance between points A and B increased beyond the physiological limit, the ligament could not maintain its elastic behavior and the ligament failed. So the limitations of a study was that it has no control group. There is a radiological study with possibility of measurement errors, and we use dynamic X-rays to identify instability, and there are possibilities of false negatives. So we conclude that ligamentum flavum buckling not appreciable on static MRI can be identified using dynamic MRI, and it is important to identify buckling preoperatively and address it during surgery. And buckling is related to intervertebral instability, but not to age or disc height in the cervical spine, and can be predicted using dynamic X-rays of the cervical spine. Thank you.
Dr. Kalyan, does this translate into clinical utility in terms of management?
Yes, sir. Good morning, sir. Sir, basically, dynamic MRIs are not something which are done everywhere in the world because of financial constraints and availability. So in such places where only X-rays can be done, we can get a fair idea based on the instability that the levels where buckling is possible, and based on that we can decide on the possible approach, anterior or posterior, and then levels.
Have you used this for deciding your surgical approach?
We did not study.
Or this is hypothetical.
How did we?
That you could use.
Yeah, we did not study the approach following the dynamic MRI, so we did not do that. But it is reported already that the buckling may decide the number of levels and the approach.
Dr. Kalyan, so would you recommend in clinical practice for all the patients of spinal lumbar canal stenosis to get or cervical spine to get a dynamic MRI done?
Yes, sir. Yes, sir. We follow it in our center, and we do recommend that dynamic MRI should be done wherever available to all patients with degenerative cervical myelopathies.
I'm all the time worried about advising the dynamic MRI, because dynamic MRI is going to cause the buckling. And yes, this buckling can lead to the neurological injury when patient is in gantry. And certain patients, some patients, they are really critical as well.
Yes,
so when you advise flexion extension, do you really put the probe, all the time? Because that is very important, because they may drop the SpO2.
Yes, sir. We do always maintain the saturation probe, and we always do it under supervision only. And we have not encountered any neurological or other complications during dynamic MRI. So we have done that study as well on X-rays as well as MRI, dynamic films and their complications.
Did you compare with? Sorry, did you compare with any of the symptoms? Because sometimes they complain extension giving rise to fall.
The study, actually, the study which I mentioned studied about neurological complications. And then there were reports of neck pain and pain which limited the 30-degree of the criteria which we took, the 30-degree of movement which is required from the neutral. So that was possible, but we did not study vertigo and etc.
And Dr. Kalyan,
Yes,
many patients just don't have enough lordosis produced in their
yes, sir.
movement.
Yes, sir.
So even when you try to do dynamic
Yes,
X-rays,
yes,
they don't go in enough of an
yes,
extension.
sir. Yes, sir.
What is the way out during study of those patients?
Yeah, we excluded those patients from our study because we only considered those MRIs where 30° was possible in either direction. Yeah, as you mentioned, sir, in OPLL and patients with significant degenerative changes, the 30° of movement may not be possible, and such patients were excluded from my studies.
Thank you, Dr. Kalyan. That was a great presentation. Thank you very much.
Thank you so much.
Move on to the next presenter. They call upon Dr. Sudhir Kumar to talk on dynamic cervical MRIs.
Title of my study paper is Dynamic Cervical MRI, an important diagnostic and preoperative planning tool in cervical myelopathy. In the preoperative planning of myelopathy, the following factors influence the decision making, like pathology, OPLL or a disc cost-effect complex, number of stenotic levels, single or multi-level, grade of cord compression, mild, moderate or severe, and whether anterior or posterior cord compression is present, and whether sagittal alignment of cervical spine is maintained or not. Based on these factors, an anterior or posterior approach will be chosen, and there is a lot of debate among the surgeons, and still there is no consensus among them. An MRI done in static position of the neck is investigation of choice currently to establish diagnosis and draft a preoperative planning, but it can underestimate the degree of stenosis or even miss the compression levels. And the dynamic factors responsible for the myelopathy can be missed. So an MRI done in dynamic position like a neck flexion and extension can reveal the true picture. In flexion, the spinal canal widens and cord lengthens, and hyperintensity signals of the cord are more clearly visible. In extension, there is an increased severity of the pre-existing compression levels, and additional levels of stenosis can be revealed, which can potentially change the surgical plan. And with this background, the research question is the dynamic MRI useful for the preoperative planning? Will it alter the surgical procedure and approach? Will it increase the concordance among the treating surgeons? And our hypothesis is dynamic cervical MRI will be superior to static MRI in the preoperative planning. And aim of our paper is to evaluate the usefulness of dynamic MRI in preoperative planning of myelopathy. And the objectives are to study the change in the surgical procedure and approach, and to study and compare the concordance score among the surgeons based on both static and dynamic MRI. And the methodology we followed is we have selected 30 consecutively previously operated patients in our institute. Static and dynamic MRI images were retrieved. Both the T2 mid-sagittal and the corresponding axial images at each level were collected and given to 4 spine surgeons. They were blinded to the procedure performed on the patients, and the identity of the images were concealed. And they were asked to provide the surgical approach and procedure for the given MRI images. Based on their responses, we have calculated the decision changes in surgical procedure and approach by chi-square test and the level of agreement by concordance score. And a few case examples. In case 1 scenario, we can see the cord compression at C5, C6 in all the 3 positions of the neck, and there is no change of plan. Coming to case scenario 2, in static MRI, you can see the cord compression at C5, C6 level, whereas in extension, you can see multi-level cord compression. And here, the C5, C6 ACD of procedure in static MRI has been changed to C3 to C6 laminectomy and lateral mass fusion in dynamic MRI. Coming to results of our paper, 3 out of 4 surgeons were significantly influenced by dynamic MRI, and they have changed their surgical procedure after viewing the dynamic MRI, which is statistically significant. A total of 48 out of 120 changes in surgical procedures were noted, with a chi-square value of 18.33 and p-value less than 0.001. And concordance score for the change in surgical procedure is from 2.80 has been changed to 3.16, and the p-value for the concordance score is statistically significant if at least 3 surgeons were considered as concordant. And the change in surgical approach for each surgeon also followed the same trend, with 3 out of 4 has been significantly influenced and changed their surgical procedure after viewing the dynamic MRI, whose p-value is statistically significant, with a total of 33 changes in surgical approaches were noted. And the concordance score for the change in surgical approach has improved from 3.13 to 3.46 after dynamic MRI, with a p-value of 0.03, which is statistically significant for all the 4 surgeons. Coming to discussion, MRI done in extension position of neck reveals additional levels of stenosis because of the dynamic factors like ligamentum flavum or instability, and the pincer effect on the cord can be visualized. So overall, it unravels the true picture of the cervical myelopathy. And coming to Nigro et al. Study, they performed a static MRI and found 156 compression levels with predominant anterior compressions, and the same patient, when they underwent dynamic MRI, has found 186 compression levels with a predominant posterior cord compressions, which is in line with our study, with an overall increase in number of stenotic levels, and there is a change in decision towards posterior procedures by surgeons after seeing the dynamic MRI. And Mueller et al. Study has been done to find out the influence of dynamic MRI on the surgical management in cervical myelopathy, and they have found that 87% had a change in surgical plan after dynamic MRI, and 40% had a change from anterior to posterior surgical approach, which is in line with our study, with a total of 48 out of 120 changes in surgical procedures, and a total of 33 changes in surgical approach were noted. Both are statistically significant. And a study by Kim et al. Done for a number of stenotic levels for the clinician agreement, and they have found that out of 4 reviewers, all the 4 reviewers have noted that more number of stenotic levels on the extension MRI, and their concordance has improved on extension MRI compared to neutral MRI, which is evident by interclass correlation coefficient, which increased from 0.67 to 0.81, which is in line with our study. And there is an increased concordance among surgeons for both a change in surgical procedure and surgical approach. And a systemic review and meta-analysis paper on adjacent segment disease stated like multi-level surgeries has less incidence of ASD because it includes the higher risk levels, which is in our study, we can see that multi-level posterior procedures increased with dynamic MRI, and it could possibly lower the ASD incidence in these patients. And the limitations were it is a complete radiographic analysis and preoperative planning study with no analysis on the clinical outcomes. And coming to conclusion, dynamic MRI is a valuable tool in evaluation and surgical decision making in cervical myelopathy with a higher degree of concordance among the treating surgeons, but it needs a further prospective evaluation of clinical outcomes. Thank you.
Thank you, Dr. Sudhir. But do you imply that your change of decision of surgery from a single level ACDF changed to multi-level posteriorly just based on dynamic MRIs and not taking clinical evaluation into consideration?
Good morning, sir. So this is a pure radiographic analysis. This was done as a pilot study to implement as a prospective study, sir.
But in your clinical practice, I mean, it's a bit far-fetched to feel that, just based on your dynamic MRIs, you'll take a decision rather than you not to take the clinical aspect of the, evaluation.
So clinical factors has to be taken, sir. I agree with you, sir. Based on the severity of the cord compression and the amount of the spasticity, all we have to take. But this is only a pilot study, and still we are studying, sir. Hope with a prospective study, more outcomes can influence our decision, sir.
Okay, thank you. Any other question?
Dr. Sudhir, are you aware of the fact that most of these patients have changed their normal, usual posture from lordotic to neutral or sometimes even slight flexion? And it's not that they cannot go in extension, some of them, but they prefer to stay in a neutral or little flexion. Does that tell you that the approach should be related to their posture keeping, telling you in which position the cord is getting compromised, which they don't prefer clinically themselves?
Sir, posture, I agree, sir. Posture, they will come to neutral or mild flexion.
Yeah, during their normal day-to-day functioning.
Yes, sir. Yes, sir. So here we aimed to look at how the extension is happening and look at the radiographical only, sir.
Thanks. Bharat, a quick question.
Sudhir, did you consider the tandem stenosis? Because, the posture will change as Dr. Ingalalikar sir said. So that would certainly matter as well. And along with that, I think the X-ray analysis, did you ever plan to do that?
No, sir. No, sir. We have not done X-rays in this, sir. It was only survey among the 4 surgeons using the pure MRI images, static and dynamic, sir.
In fact, the ideal thing would be to do patient's X-ray in neutral standing, his neutral standing, and keep his neck posture in that posture during MRI. Then you will truly know how comfortable he is.
Yeah. Yes. Okay.
If there are no questions, we'll just move on to the next paper. Thank you, Dr. Sudhir. It was a good presentation.
Thank you.
May I call upon the next speaker, Dr. Aju Vasco, to talk about his proposed classification on lumbosacral tuberculosis. Dr. Aju, please.
Greetings from Madras Medical College. I will be presenting a classification based on surgical treatment strategies for restoring spinal stability in advanced lumbosacral tuberculous spondylodiscitis. The need for a classification to address the surgical challenges in lumbosacral spinal tuberculosis can be best understood by the following case examples. These are two cases of L4-L5 tuberculous spondylodiscitis, which were managed with posterior stabilization. 3 months after surgery, both the patients had fixation failure, leading to poor functional outcomes. The unique lumbosacral anatomy and biomechanics of the lumbosacral spine will determine the pattern of disease progression and development of deformity in lumbosacral spinal tuberculosis. Even a moderate destruction of the vertebral body or the intervertebral disc can result in significant loss of lordosis and poor functional outcomes. While early lumbosacral tuberculosis can be successfully managed with chemotherapy alone, advanced lumbosacral tuberculosis with extensive destruction of the lumbosacral spine leads to hypolordosis or kyphosis, instability, leading to loss of lumbosacral biomechanics and poor functional outcomes. Surgery remains the mainstay of treatment in advanced lumbosacral tuberculosis. The factors which dictate the choice of strategy to reconstruct the lumbosacral spine in lumbosacral tuberculosis with extensive destruction are the unique regional anatomy and biomechanics, fixation difficulty in the diseased bone, loss of sacral bone for implant anchorage, and shear stresses at the lumbosacral junction. Previous studies have published the outcomes of treatment of lumbosacral spinal tuberculosis using various surgical methods. Yet, literature lacks evidence-based guidelines on the levels of instrumentation, the choice of distal anchor points to effectively stabilize the lumbosacral junction, and as to when an anterior reconstruction is needed. We did a single-center prospective cohort study on 51 patients of symptomatic biopsy-proven advanced lumbosacral spinal tuberculosis. All patients underwent a transpedicular biopsy and received a standard 9-month chemotherapy. Surgery was indicated in cases with clinical or radiological evidence of instability, including a vertebral height loss of more than 30% or a translational displacement, a deformity with loss of physiological lumbar lordosis, accompanied with or without neurological deficit. Patients were classified into specific types based on the increasing severity of destruction of the lumbosacral spine, and appropriate surgical strategies for reconstruction were proposed, incorporating the biomechanical principles of spinopelvic fixation. In a type 1 lesion, which is L4-L5 tuberculous spondylodiscitis, the lumbosacral spine was stabilized with posterior stabilization using 4 proximal anchors and 4 distal anchors. In a type 2 lesion, which is L5 tuberculous spondylitis, posterior stabilization was achieved with at least 4 proximal anchors at L3 and L4 and 2 distal anchors at S1, with supplemental iliac screws if the fixation in S1 was inadequate. In a type 3 lesion, which is an L5-S1 tuberculous spondylodiscitis, in which the sacral promontory was destroyed, which precludes the placement of an S1 screw, and the sacral ala was intact. Lumbosacral spine was stabilized with spinopelvic stabilization using 4 anchors proximally and 4 distal anchors using alar screws and supplemental iliac screws. In a type 4 lesion, in which both the sacral promontory and the sacral ala were destroyed, the lumbosacral spine was stabilized with spinopelvic stabilization with 4 proximal anchors at L4, L5 and 2 distal anchors using bilateral iliac screws alone. In scenarios in which a vertebral height loss was more than 0.5 and in which there was an anterior column deficiency after debridement and restoration of lordosis, an anterior reconstruction is recommended. Outcomes were analyzed based on the following parameters. This is a type 1 lesion which was managed according to this classification, and at 3 years follow-up, the patient had good radiological and functional outcomes. This is a type 2 lesion which was managed using spinopelvic stabilization with S1 and iliac screws as distal anchors. At 6 years follow-up, the patient had good outcomes. This is a type 3 lesion in which the sacral promontory was destroyed, but both the sacral ala were intact, and spinopelvic stabilization was done using bilateral alar screws and iliac screws. At 42 months follow-up, the patient had good outcomes. This is a type 4 lesion in which both the sacral promontory and ala were destroyed, and this was treated using spinopelvic stabilization with bilateral iliac screws alone as distal anchors, and the patient at 8 years follow-up had good functional outcomes and radiological outcomes. This is a scenario where an anterior reconstruction was done. The postoperative CT showing the placement of bilateral alar and iliac screws. A total of 51 patients were treated. Bone healing was seen in all patients at a mean of 8.5 months, and the global lumbar lordosis was restored to physiological limits in all patients. Good functional outcomes were seen as evident by the significant improvement in VAS scores and ODI scores. All patients showed complete neurological recovery. In 47 patients, medical therapy of 9 months was sufficient. These were the complications which were managed successfully. Surgical treatment of advanced lumbosacral tuberculosis remains difficult and controversial. There are few detailed studies on the surgical strategies in lumbosacral junctional tuberculosis. No defined guidelines are available on the choice of the levels of instrumentation and the ideal distal anchor points to reconstruct the lumbosacral spine. The factors to be considered while choosing distal anchor points to reconstruct the lumbosacral junction are: 1. The amount of bone destruction; 2. The available bone for implant anchorage; and most importantly, the biomechanical stability of the implant. The farther the implants extend anterior to the point of McHod et al., the greater will be the stiffness of the construct. In scenarios in which there was a poor hold of S1 screws, supplemental iliac screws added to the stability of the construct. A combination of alar and iliac screws offers 4 distal anchor points as against 2 anchor points, which is achieved with bilateral iliac screws alone. The classification serves as a useful guide by providing appropriate surgical strategies for reconstruction of the lumbosacral spine based on the increasing severity of destruction of the lumbosacral junction. It helps choose the ideal distal anchor points based on the biomechanical principles of spinopelvic fixation. It defines specific scenarios when an anterior reconstruction is needed. It helps reconstruct the lumbosacral spine and restores the stability at the lumbosacral junction. The current study has shown that patients treated according to the recommendations of this classification have achieved good clinical, functional, and radiological outcomes.
Thank you very much. So are there any questions?
Did you do CT scan in all these patients?
Yes, sir. Yes, sir. We did a CT scan in all these patients.
Okay. Are you aware of the fact that whenever the chronic lesion like tuberculosis is there is a regional osteoporosis?
Yes, sir.
Ordinarily,
yes, sir.
also suppose you have wherever the tubercle spine is there, the adjacent levels are not that good a hold like a normal level would have.
Yes, sir.
Did you
so
have
that
to,
that's
any time go more than 2 levels up?
No, sir. Actually, in most of the published papers, they have recommended monosegmental fixation, 1 level above and with 2 iliac screws below. But we have increased the fixation, proximal level fixation with 1 more level above, because we found that in most of the cases which we had operated previously before 2007, the adjacent vertebrae was also, though the MRI, the X-ray looked normal, the adjacent vertebrae was also osteopenic, and the pedicles didn't have good hold with monosegmental fixation, and we had our fair share of failures. That's why we fixed 1 more level above, but we took care not to destroy the facets, and when the lesion healed, we removed the screws.
Yeah.
Okay, Dr. Aju, one quick question. What about, did you study the anterior sort of reconstruction? In which type cases do you need anterior reconstruction? You just mentioned that type 3, you need anterior approach and anterior reconstruction, but you can do it all from the back. That's another question.
Yes, sir.
But did you study which ones require anterior support also or not?
Yes, sir. I mentioned, sir. Actually, that is one highlight of this classification. In cases where vertebral body height loss was more than 0.5, after a posterior stabilization and restoration of lordosis and debridement, and there was a large anterior void, we did an anterior reconstruction, sir. I mentioned that, sir.
So in which type? So in which types would you need to do an anterior reconstruction? That's my question.
It is not the type, sir. In type 1, it is not needed, but in last 2, types 3 and 4, after where the destruction is more, after we debride, if there is the loss on CT, the post-operative CT after showed a loss, or the pre-operative CT on evaluation showed that the destruction was more than 0.5 vertebral height loss, we recommend an anti-reconstructions.
Dr. Bosco, good morning. Excellent results. Any case of implant prominence? Because most of these people are emaciated people. They are in kyphosis because of multi-level collapse.
Yes, sir.
And these can cause a problem. Did you need to revise them, or how did you go about that?
Sir, actually, while placing the iliac screws, we started the iliac screws on the ventral side of the PSIS. We attempted to do that, and we made a trough so that the head of the screw sat inside the trough. So that way we avoided implant prominence. But in 3 of our cases, we had to remove the screws at 4 years because of implant prominence.
Thank you, Dr. Raju. It was a good presentation. May we now move on to the next presentation. And may I invite Dr. Nagaraj for his presentation on finite element analysis for decompression and interbody fusion. Dr. Nagaraj, please.
Good morning, everyone. Myself, Dr. Nagaraj from AIIMS Rishikesh. Today, I am going to briefly explain about our study titled Biomechanical Analysis of Instrumented Decompression and Interbody Fusion Procedure in a Lumbar Spine, a Finite Element Analysis study. The study was conducted in collaboration between AIIMS Rishikesh and IIT Roorkee. Lumbar degenerative disorder being one of the significant cause of disability in mankind, the surgical fixation is being considered as a standard of care. The multiple surgical fixation like posterolateral fusion and interbody fusion methods are being used, out of which the TLIP and PLIP are most commonly done interbody fusion methods. Till now, multiple clinical studies have done to know the superiority of one procedure over the other, but there's a lack of biomechanical studies in this field. If you compare interbody fusion with the posterolateral fusion, the clinical studies show similar results, but it is not supported by biomechanical studies because of sparsity of studies. If you compare TLIP with the PLIP, the clinical results show both having similar results, but TLIP is preferred over the PLIP because of its ease of approach and decreased blood loss during the procedure. But there is a controversial result in the biomechanical studies. So we took the objective to analyze the biomechanical stability of the instrumented laminectomy and interbody fusion procedures, either PLIP or TLIP, in the lumbar spine. For this, we have to prepare a virtual model of lumbar spine. For that, we utilize 5 different type of softwares. For generating surface model, the materialized mix was used. For generating solid model, materialized schematic was used. ANSYS space claim for partitioning of the solid model, assigning the material properties. We used Hypermesh and Abacus for final simulation and results and assembling of the elements and load application. The Abacus was used. Here I am briefly explaining the procedure. The first, for generating the surface model, we took the CT scan of the patient, and with the help of thresholding, we took out the whole skeletal framework of the patient, and it was loaded with the noises. With the help of region growing, we removed the noises, and final skeletal framework of the patient was taken, and the surface model was the required part of the spine was extracted with the help of split mask, and we developed the solid models. That is, the surface model was converted into the solid model, because if you want to apply for finite element analysis equations, it should be a solid model, and the spikes and the holes were removed and it was made smooth. And the same way, the intervertebral disc was also made solid. After that, we partitioned, and material assignment was given with the help of space claim and hypermesh. The vertebra was divided into cortical part and the cancellous part. In the same way, intervertebral disc was divided into end plates, nucleus fibrosis, and etc. And after that, using the Abacus, we created the functional spine unit assembly, and we joined the intervertebral disc and then vertebra with the tie constraints, and thus the facet joints with the surface to surface contact. To mimic the ligaments in the functional spine unit, we use the connector. The type of connector used was axial spring, and the behavior was tension only. For the boundary condition, the lower vertebra was used as a constant vertebra, and the upper vertebra with respect to lower respect to movement was measured. That was cos theta, the angular displacement, and the loading was given on the upper end vertebra. And the material properties was used in the study was taken from the literature, and basically what we measured was the angular displacement. It is nothing but the dot product of initial vector versus the final vector. and then the results were tabulated. Here I'm just showing the only in the flexion motion. If you are seeing here, the red means there is the more displacement, that is the cos theta value. The same way we calculated for extension, the left lateral bending, right lateral bending, right torsion, and these are the cos theta value, the angular displacement. Then the whatever the values we got, and it was validated with the literature, that is the Yamamoto study, and it was consistent with the Yamamoto, and our model was validated. After validation, our model was ready for modification. We modified the FE model to our requirements, to posterolateral fusion and different types of interbody fusion procedures, TILIF and PILIF. And after calculating the theta value or the cos theta value or the angular displacement, what we calculated was the percentage of reduction in ROM in all the degrees of motion between the laminectomy and interbody fusion procedures. Here we can see there is no difference between the posterolateral fusion and interbody fusion in flexion and bending and lateral bending, and but if you see in the extension and the torsion, there is a huge difference. That is more than 6% difference between the interbody fusion and the posterolateral fusion. So both in extension and in right torsion and left torsion. After that, what we compared was the reduction in the ROM in all degrees motion in the unilateral pedicle screw fixation and bilateral pedicle fixation in interbody fusions. Here we can see, if you compare in unilateral pedicle screw fixation, whether it is in PILIF or TILIF, there is no such difference. There is a less than 5% difference in unilateral pedicle screw fixation, or if you compare bilateral pedicle screw fixation, whether it's in TILIF or comparable. After that, we concluded that if you, whatever the procedure, if it's a PILIF or interbody fusion procedure, the pedicle screw, if you use pedicle screw instrumentation, it will decrease the ROM in comparison with the intact FEM model. If you compare posterolateral fusion with the interbody fusion, then interbody fusion procedures, whether TILIF or PILIF with the bilateral pedicle screw fixation, is superior or stable in extension and in torsion. If you compare TILIF with PILIF, it is comparable. There is a comparable decrease in ROM, whether it's unilateral state or bilateral pedicle screw fixation state. If you compare unilateral pedicle screw versus bilateral pedicle screw fixation, then it's obvious. Bilateral pedicle screw fixation is stable in flexion, extension, and bending than unilateral pedicle screw fixation. Any questions? Thank you.
Isn't this already proved in the literature by experimental studies?
Good morning, sir.
Isn't this already proved in the literature by various biomechanical studies?
There are multiple clinical studies, sir, but there are very less biochemical studies. So we thought of making a biomechanical studies rather than a clinical study.
No, I'm talking about biomechanical studies, lab studies. Hasn't all this been worked out long ago?
There are multiple, but compared to clinical studies, there are less studies in biomechanical studies, and they are showing controversial results are there. So we did a biomechanical study.
Because I think every manufacturer will bank upon the available biomechanical data and come out with something new.
What's it? I didn't get it.
See, compared to you and me, yes, all manufacturers and product designers will heavily bank upon the lab data, which is the kind of you have done.
Yes, sir.
It has been available for a long time. How does it clinically, does it tell you anything different that you already knew?
Sir, actually, that's what, sir. We just want to reinforce it. Whether the studies we have done, some studies are controversial. They are like TILIF is better and PILIF is controversial. This is not superior to over the TILIF.
No, but they are not for the biomechanical reasons. Their plus minus points are related to the approach, to the neural trauma, etc. Not so much for the biomechanical stability or instability.
Sir, in some study, they have shown, actually in our study, we showed
torsion and extension is differential between posterolateral fusion and interbody fusion. But some of the studies, there is a difference in flexion. So there is like not a single result.
Okay. Does this tell you to protect the spine post-operatively by giving space or restricting activities till it heals?
No, sir. Here we have not compared.
Does that make any difference to your post-op management?
Yes, sir. Obviously, sir. If till now there is nothing constant value to know which is unstable spine. So in our study, what we did, we calculated something called a constant value. That is, if there is a difference of reduction in ROM less than 5%, we consider it as a stable. If it's more than 5%, then we consider it as an unstable, so that we can assign which is stable procedure and which is unstable.
So you have changed your protocols after that?
Yes, sir. Our study is still yet to complete, sir. Last part, because that constant thing is we are working on it. So after that, we are going to.
Okay, thank you.
Yes.
Thank you, Dr. Nagaraj. It was a great biomechanical presentation, and I congratulate you on doing finite element in our own country in collaboration with IIT. So that concludes this interesting session. And may I now request the person after whom this prestigious session of the ASSI has been made, Professor V.T. Englalikar, sir, to give his final conclusion, sir.
Number one is all papers were above average. And I'm very happy that along with clinical research, which was being done all these years, last 5 to 8 years, we are finding more and more basic sciences studies, more and more engineering studies are being done. And what we had earlier known or what we practice, either validation of that or inconsistencies of that are being pointed out. All presenters were good, and all in all put together, the session was good. Only thing is, I feel in some of the papers, the presentations were done too early in the life cycle of a study. If you need to do more work, it is not necessarily mandatory to do a primary reporting or a primary submission of a report, because those later on, those results are never published further. And the study is aborted after from 30 to further 5 patients, the studies are aborted and stopped. So we don't know what has happened to those studies further. So I think all these people must consistently follow it up and get on with 200 or 150 patients and report it to the audience again. Or don't be in a hurry to publish it. I'm talking in general. But this is all in all put together good session, and I'm happy that we have a standard which is really good. Thank you.
Thank you, sir. Thank you, Dr. Arun Jaiswal and Dr. V.T. Englalikar. We know you are the man. Hope the judges have already marked and passed on the results to Gautam Zaveri to announce it in the GB next. We'll have a research for 10 minutes, and we start with the research awards presentation and the awards papers to be presented at around 9 o'clock. So please log in at 8:55. Thank you all. Dr. Gautam, you want to say something?
No, thank you very much to Professor Englalikar and Professor Arvind Jaiswal for moderating this session so beautifully. I thank all the young boys who have presented so brilliantly, but I have a suggestion to make to all of you. Look at Dr. Englalikar, look at Dr. Jaiswal, look at Dr. Rajsekharan. All of them are properly clothed. Look at you, and you have come to a very important session, which is the prime session in VTI. You have not shaved yourself. You are coming in t-shirts. It reflects badly on you and the fact that you do not respect this session. So I'm very disappointed with that part.
Even Gautam has put on a tie. I mean, I've not seen Gautam wearing a tie for ages. Great.
Yeah. So, Gautam, if I can just take 1 minute, I would like to reiterate what you said. I mean, younger people should get off the idea that being casual or being over casual is cool. This word cool and chill and other things is really good for life, but not good for academics. And when you're in a society, it's different from social happenings. So I'm glad you brought up this point. I was actually thinking about it, but I was a little bit hesitant. But Gautam is always outspoken, so good, Gautam. I congratulate you for telling this.
With that,
Can't agree more, sir.
It is 8:45, and we can stay online. We don't have to go off. We can chat a bit. We'll start the next session in 5 minutes time at 8:50, which is the ASSI award session, and that is.
Sir, we are on live. Sir, we are on live streaming. They can stop live streaming for 10 minutes if required. If we are going to chat around, yeah.
That's a good idea, Paji. Sushil, can you stop the live streaming, please? We want to continue using your platform, but stop streaming it live for 10 minutes. So, Soumyajit, yes, the interview with Gary Lenke was unbelievable. It was fantastic. This gave us insights into the personality of the person.
Absolutely.
It gave us insights into the development of the human being as well as development of his work. And it gave us some very nice take-home messages. It was meant to be for youngsters, but I think all those take-home messages were as applicable to us as they were to the youngsters.
No, I do congratulate all the ASSI program designers to put this session on legion. It was great. And it was not only Dr. Lenke, all the speakers were great. And looking forward to a similar session in the evening. It's a great addition. Thanks, Gautam.
Yeah, no, I must say that I think even VTI sir, we enjoyed your interview. Ankur and I were just talking before this session that what we need to do is to learn that there is life beyond medicine, and it's time that we start looking. I mean, along with doing good work and everything along with that, we also need to look beyond that and start, planning and looking for a hobby, something to de-stress yourself. And that's a very vital message that was conveyed in your case. And also the effort to get an organization together. I mean, I joined much later in 2002 when I came back from England, but and I remember the efforts made by Professor Jaiswal when he was the president, and I used to pester him, sir, ye nahi ho raha hai, wo nahi ho raha hai, and he had the patience to listen to us. I somehow feel that I lack that kind of patience with people, and maybe we'll grow into that. He used to listen to me. He used to say, "Tum karenge," and it has grown into an institution.
Yeah, I remember the young Gautam with all the hair intact and all back and bubbling around, and so all the driving enthusiastic Gautam on the panel on the floor mic, and great. We funnel from distance.
Arvind, high intelligence and high energy is a basically bad combination, but Gautam has tuned it out into a beautiful thing.
No, add on the volume also.
Lost my intelligence, energy still nice, sir.
So I must take this opportunity to congratulate Gautam on being diagnosed as coccydynia. Because of the long hours, he was sitting
all through, whole day he was there.
And Saturday. And congratulations, Gautam, for developing coccydynia. You've been an example to all of us.
Yeah, but the last thing I want surgery is surgery, my friend. I'll sit on sits baths just to get my coccydynia relieved.
Well, the sincerity and intensity of your sitting tight should reflect into coccygeal pain following days.
Yeah. But again, Gautam, I absolutely agree with you. Not only was Laddie's interview fantastic, he actually
it's excellent.
He actually made a lot of effort to sit through it, and he made a lot of effort to cancel his schedule. We interviewed him on Wednesday night, and Wednesday is his full day clinic. So he took out full 1 hour from the clinic, and all these CVs and all these presentations he shared, and I edited them and again wrote it back to him. to say whether you are comfortable with the questions. And he never blinked an eyelid. He said that I am absolutely comfortable with the questions. And I think the questions you have framed are extremely logical and relevant. So you should go ahead with the interview. And after the interview, he said that I have another emergency meeting. I might not be on live, but leave a message. I text him just before the interview was live. And just after the interview was finished, he texted me back that, sorry, Basu, I missed it. Did it go on well? And I said it went on extremely well, sir. And then he replied back.
Amajit, sorry, sir.
He said, texted back that I'm looking forward to meeting you guys later on today.
Amajit, so did he send that presentation, or you made the presentation?
Most of it I made it. He mailed some.
Okay.
Basu, apart from your level of comfort with him, which is extremely important for an interviewer and interviewee, it shows his regards for ASSI.
Absolutely.
I am looking at all these overseas faculties. They're wanting to present paper, wanting to speak, be alive, wanting to be alive at all hours. I think it reflects what credibility ASSI has at international level.
Dr. Lenki has actually a very high regard for these two associations, the Chinese and the Indians. I mean, he has got a very high regard, and he always says that the entire effort of globalization is because of the fact that these two countries are doing phenomenal work. You know, when he was the president, he was the first SRS president to organize a globalization conclave. And Dr. Raj Shekharan and myself were the only invitees to attend that Chicago meeting. Dr. SR had to drop out in the last moment because he had something important coming up. So I attended that. So he utilized special funds from the SRS to build up a globalization conclave. And he mailed us all the important elements of globalization which we had to study and present those cases. And he is a fantastic person, really.
Unfortunately, he was not live, Samyajit. Otherwise, I wanted to ask him that on one hand, he does these complex, seriously ridiculous deformities. And on the other hand, when he had a foot drop following a following an L5S1 disc, he himself did not get operated. Please.
So he didn't develop a foot drop, Gautam. He did develop a small amount of weakness, but he had an epidural short root blocks. And then within 6 weeks, he did very well and he recovered. Otherwise, he would have got it.
Gautam,
tomorrow, if I have a spine problem, I'll be the first person to go to VTI sir and say, sir, use up all your skills. I know I am lacking all these conservative skills. Then only I'll go for surgery.
Gautam, Arthur Staffi from Cleveland. I was with him. And at the end of a major surgery, he kept on pressing his back. I said, what happened? He said, I have grade 1 listhesis. How long? He said, it's about 10 years. And I have root pain. I said, why don't you undergo surgery? Oh, it's not for me.
I think all of us even saw Professor Harms.
Yeah.
And Professor Harms has got such a bad degenerative scoliosis. He was barely able to walk. So,
but he wouldn't want to undergo surgery.
Well, I think there was a survey in the US many years ago about how many spine surgeons had undergone spine surgery for fusion for back pain. And in the whole of the US, only one surgeon had undergone surgery.
And in the whole of ASSI, I know KVM is the only person who underwent that.
Yeah, only brave person. But he had a...
And Arvind
Dr. Harms, actually, Professor Harms had a surgery, had foot drop, actually. He had foot drop.
He had a surgery, is it?
He had DVT. He underwent surgery. He had DVT. He had foot drop. He recovered from that and he was...
I think Michael Roof operated on him. Correct me if I'm wrong, Apache.
Oh, sorry. I thought he was...
during our conference.
Right. I think it is 8.
I am happy that I chose the topic of my oration as I have, because that is what you have all been discussing. And VTI sir, I think you would be perhaps now happy to see the seed that you had sown way back in 1982 blossoming.
I feel fulfilled.
So from the discussions, I am relieved that the topic that I chose is very relevant to the present era. So
during this COVID period, lots of patients who needed surgery in terms of everybody's decision that this patient deserves discectomy, etc. A lot of patients recovered. And I two young surgeons confessed to me, "Sir, we never believed what you said that the patient can recover without surgery. We always believed that as per the XYZ protocol, we must operate upon this. But today, our own patients have recovered, and we realize that they can be treated non-surgically."
Exactly, sir. And this is what I've mentioned in the editorial. I have written up the editorial in the last issue, and this is exactly what I've written up. That the COVID has taught us the natural history of many disorders which we did not know up till now.
Yeah, it's not that they didn't know, they didn't give importance to it. And I think they were forced to give attention to that by the circumstances.
I won't say anything now because I have half an hour to convey my
session, sir.
Right, my experience in this regard. I may bore you then, but
Sushil, can we start live streaming again?
5 minutes.
5 minutes
5
more.
minutes for the next program. 5 minutes.
Samir, I'm really looking forward to today's interview with Larry and Goel.
It was nice, but it was calm. I mean, the fire. I didn't allow them to get into fireworks. But it's very difficult to control these two guys for just 20 minutes, you know.
Only Samir Dalvi can do it.
Yeah. I think you look forward to the time when these juniors will be interviewing you and me together. 10 years, 20 years from now.
So one thing in common. With one thing in common. A shaved head.
That is a subtle hint dropped, right?
Ankur, for this session, do we have slides for introduction, or all those people don't need any introduction?
Sir, as such, there are no slides, sir. There is no introduction required.
They don't need any introduction,
Yes,
right? Right.
Appaji, can we start? Sushil, are we live?
Sir, 2 more minutes.
I think
2 more minutes. It's 8:56.
Kya bola,
Yeah,
Deepak?
it's
4 minutes to go.
No, that's fine. But can you start live streaming? We'll start 4 minutes early.
Sir, then you have to tell me, should we start streaming, sir?
I think we should have gave another 3 minutes because most of the participants would be there. I mean, most of the listeners would be tuning in at 9 a.m. only.
Yeah.
So we have reached that stage where we are ahead of time, right? Starting ahead of time.
Yeah,
That's good.
Actually, in the proverbial time, we are ahead of time.
Right.
We'll start in 2 minutes, sir. We'll start in 2 minutes.
Like Indigo Airlines, we leave off early and reach early, right? But Swaminathan, you had prepared quite well for the interview, right?
Dr. Rajsekharan, operate. I can see from here.
I have.
Right. Sir has to do Ajoy's role also these days, so that's why he's been very busy.
No, I am not Professor Gautam. Hey, Gautam, next Sunday you must teach us a crash course on stock market, what you are talking about. He said he has earned more in stock market in COVID time. So, that is leaving me restless and sleepless.
Sir, also fitness.
Everybody, Raja, I think in the last 9 months, 40% increase in my stock portfolio.
Okay. Mine is 0, so it can't increase. So I
No, Dr. Rajeshekharan, don't worry. I have lost last 4 years savings in stock market. I have lost it. So there are some who gain and some who lose. That's the difference.
Sir, how is
Luckily,
you are on zero. Luckily, you are on zero.
The guy who is well shaven has won, and the guy who is now growing a beard has lost. It's so.
We will be live in 1 minute. Live in 1 minute.
Okay.
Yeah. We'll be live in 1 minute. Yeah. We can.
Ajoy is doing well, sir.
I'm going to search. Yeah.
Ajoy is doing well.
To Ajoy this morning. He is at back home. He is getting bored. Wants to rejoin work. I have advised him 3 weeks of bed rest. Raja will kill me for that.
If you ask him for 3 weeks bed rest, he will have suicidal tendencies. He must join work.
Yeah, they say next day you should join work. That is the current. That's what the cardiologist told me. But
Very true.
He can take it lightly whenever he wants to.
Bed rest is counterproductive.
Yeah, bed rest they
So
say.
we are live in 30
seconds. And bed rest they say.
Yeah, we are live.
live in 30 seconds. Sir.
Good morning, sir. Good morning, everyone.
Yeah. Good morning. everyone. So we are starting our prestigious ASSI session now.
Appaji,
This is a
we are not
research
yet
award
live.
session.
Appaji, just hang on. We are not yet live. Deepak, how many seconds? Deepak, how many seconds?
Yes, sir.
Wait for the coordinator to announce that we are live.
So we are live.
Good morning, everyone. So we are in the starting our prestigious ASSI Research Award section. I call upon Dr. Chabra and Dr. Gautam Zaveri to chair the session. Sir, Dr. Chabra and Dr. Gautam Zaveri, please take over.
Thank you, Appaji. This is a very prestigious session, and we have various achievers who will present their work. Gautam will later also let you know about the process. In fact, you would be aware about how we go about screening these awards and having them reviewed by a very esteemed panel before the winner is selected. Of course, the first talk is by someone whom you all know because he's there in each year's award session for n number of years now, and not only for one but numerous awards. He's none other than our dynamic, I won't say past president, like a president emeritus, Dr. Raja Sekharan, who will be presenting the ASSI Basic Science Award on subclinical infection can be an inhibitor of inflammaging leading to degenerative disc disease, evidence from host defense response mechanisms. So sir needs no introduction. I will just request him to deliver the talk on the award-winning work that they have done.
Sheil, please.
I have privilege of presenting our research work on behalf of our entire team. And this is on the question whether we can prove that subclinical infection can be a cause for disc degeneration by documenting host defense response mechanisms. None of our team members have any disclosures. Now, the background is that lumbar disc disease is the leading cause for back pain. Etiopathogenesis is still elusive. And the question is subclinical infection a cause for disc degeneration? This question has divided the spine community in the believers and non-believers. And the non-believers actually strongly believe that the presence of bacteria in the tissues is due to contamination. Now, one of the ways that will settle this controversy is to document the presence of humans' defense response at a tissue level. And if these defense response proteins can be documented and the biological processes established, then we will document that there is an infective process going on, and that will be a strong point towards a subclinical infection. Towards this aim, the study was done in Ganga Hospital and Ganga Research Center. And the materials for this was 10 normal MRI controlled discs from brain dead voluntary organ donors. And this acted as a control. And this was compared by proteomics with 17 disc degenerated samples. The proteomics workflow was as per the accepted international protocols. And we could demonstrate that there were 2,018 proteins in normal discs and 2,576 proteins in degenerated discs. There were a lot of important differences, but for the purpose of this study, we will actually confine ourselves to the 46 human defense response proteins that were very specific and found in disc degeneration. There were 21 HDRPs were common to both normal and degenerated samples, and only one was specific to the normal disc. Now, these HRDPs were acute phase reactants like apolipoproteins, which are very well known to be present and take a very active part in bacterial infections. Antimicrobial proteins like azurosidin, CAMP, alpha-defensin, haptoglobin, lipocalin, galactin-8, and tenacin. All are very important proteins which have a documented value in antimicrobial properties. We also documented many complement and immune proteins like A1BG, APCS, complement proteins, and also terminal complement complex proteins, which actually mean that there is a antimicrobial activity going on and there is an inflammation established. Stress responsive and antioxidants proteins were also documented. Now, we also documented 6 differentially expressed HRDP pathways. 2 upregulated proteins were found only in disc degeneration, and that was the central complement C3 and HSPG2. Interestingly, some of the important proteins which are essential for having a good immunity against bacteria, like lysozyme, SOD3, and synovial phospholipase A2, and TIM3, were found to be downregulated in disc degeneration, which means that in these tissue samples, the capacity for fighting against the bacteria was much low. So what is the importance of this study? Disc degenerative disease has traditionally been thought to be due to genetic, traumatic, mechanical, or aging. But now there is a lot of talk and documented proof that inflammaging, which is a constant low-grade inflammation, as the cause of disc degeneration. And this could be actually because of subclinical infection or dysbiosis. Last year in the NAS award paper, we documented that there is a constant inflammaging going on. And we also established that there is a subclinical infection and a dysbiosis, both of which can be the result cause for inflammaging. Now, why is this important? We know for sure that the human body contains trillions of microorganisms, and we are outnumbered by bacteria to the human cells by a ratio of 10:1. Now, imbalance between beneficial and pathogenic microbes is called dysbiosis, and we know that this can lead to immune dysregulation, autoinflammation, and also degenerative disease. There are many diseases which have been now documented to dysbiosis, and there is increased evidence. And also our study proves that this dysbiosis is present in the discs. There is an increase of HDRPs with bactericidal activity, and there is a decrease of HDRPs which are necessary and primarily involved in defense against pathogens in DD. Now, this is an important proof to show that there can be a subclinical infection which is actually causing this problem. The presence of bacteria and the presence of bacterial cell wall proteins can actually be recognized by the host as foreign and are actually called the pathogen-associated molecular patterns. And this can actually ignite a constant source of inflammation, which can be the initiate and cascade into a degenerative disc disease. The future implication of the study is that many of these proteins can be exploited as biomarkers that may help to identify at-risk or very early degeneration discs even before they have an MRI change. And they may also set a pathway to develop an early therapeutic intervention that reverses or attenuates the degeneration. I thank the ASSI for giving us this opportunity to present our work, and thank you very much.
Thank you, sir, for a very nice presentation of the work. Gautam, are we allowed questions here? No. So I'll let you introduce the next award winner. Please unmute yourself, Gautam.
Yeah, good morning. And it is my proud privilege to invite the next award winner, and that is for the SSI Young Investigator Award 2021. And the young man who has won it is Dr. Dilip Chand Raja. For his presentation on the catastrophization effects of an MRI report on the patient and surgeon and the benefits of clinical reporting, the results from a randomized controlled trial and blinded trials. Dr. Raja, all yours. Sushil, please play his presentation.
And dear colleagues, a very good morning to all of you. We thank ASSI for giving us the opportunity to present our research work. Low back pain is the most common cause of musculoskeletal disability, affecting more than 70% of world population. However, majority of low back patients will improve spontaneously, and despite this fact, there has been a tremendous increase in the number as well as the cost of spine surgical procedures performed all over the world. Number of spine surgeries has paralleled the increasing use of MRI, which accounts for 22% variability in the spine surgery rates, and early MRI has also been documented to increase days of disability in both radiculopathy and non-specific low back pain. An MRI report can negatively influence the patient and healthcare provider and can lead to hypochondria, which is person's anxiety about their health that is created or exacerbated by using internet to search for medical information. Our objectives were to study the effect of routine MRI reports and to devise a clinical method of MRI reporting and to verify the benefits of such reporting. We performed a three-phase analysis. Phase 1 involved a randomized blinded controlled trial. Phase 2 involved questionnaires, Google search and Delphi consensus model. Phase 3 was a blinded controlled trial. In phase 1, we included 44 patients with chronic non-specific mechanical low back pain of minimum 12-week duration without any red flags. They were randomized into two groups. In group A, they received full factual explanation of the pathologies reported in MRI, whereas in group B, they were reassured that the MRI was completely normal with only incidental and age-related findings. We analyzed three main parameters: the severity of pain, the perception of status of spine and disease, and the functional status at three different time points, one being the first consult, after exposure to MRI report, and at 6 weeks of similar conservative therapy. With PSEQ2 being the primary variable, the sample size required was 21 for a 90% power of the study. In the final sample, we included 23 in group A and 21 in group B. PAT t-test, independent t-test and chi-square tests were used with the significance set at 0.05. This table demonstrates that the demographic, clinical and functional parameters at first consult were similar between the two groups in the phase 1. To analyze the changes in severity, perception and functional outcomes of low back pain, it documented that group A continued to have a deteriorating effect of negative perception of MRI findings because they were factually explained down the findings. In phase 2, we performed questionnaires amongst the patients and identified frequently used terminologies which produced concern on the patient. Most catastrophic search results were documented, an alternate method of reporting avoiding search terminologies, however without losing clinically relevant information, as well as we used scientific words that gave precise information. These were the most common terminologies which caused catastrophization, such as herniation, degeneration, desiccation, annular tear, nerve root impingement, and canal stenosis. In the clinical MRI reporting, we used modified Fuhrman grading, high intensity zones, and Shiza's classification for spinal canal morphology. For MRI of 20 low back pain patients in the phase 3, we developed routine and clinical reporting, and they were circulated among 40 healthcare professionals, 10 each of spine surgeons, general orthopedic surgeons, orthopedic residents and physiotherapists. Three main parameters were analyzed. One was the severity of the spinal condition, the second was the choice of treatment, and third being the probability of requirement of surgery in future. We also analyzed the magnitude of invasiveness change after clinical reporting, whether it improved from surgery to injection or conservative management, or whether it worsened from conservative to injection or surgery. Appropriate statistical methods were used. This is a typical case example. This is an MRI of 65-year-old female with non-specific low back pain for 14 weeks duration without radiculopathy, claudication or neurodeficit. The patient already had a traditional MRI report. We developed an enhanced report and both were circulated blinded to the 40 healthcare professionals. Regarding the severity assessment, the three groups of orthopedic surgeons, orthopedic residents and physiotherapists showed the decrease in severity assessment following clinical reporting. Similarly, there was a decrease in invasiveness of choice of treatment among the three groups, and also the probability of requirement of surgery in future was dropped significantly among all the three groups. The global burden of low back pain is continuously on the rise, prompting a call for action. Although the lifetime incidence of low back pain is 85%, the natural history is one of spontaneous remission. But paradoxically, the number and types of intervention and incidence of surgery is exceedingly on the rise because of excessive use of MRI, which has over the years increased by 50%. A patient with chronic non-specific low back pain may have two pathways. If the patient has low fear, it often results in recovery. However, if the patient enters catastrophizing behavior, it may result in a vicious cycle of disuse, disability and depression. We hypothesized that this could be blocked at 2 time points, either by altering the negative affectivity which is provided to threatening illness information, or by reassurance at the primary level itself, or by providing clinical reporting. The reassurance behavior of the general practitioner or healthcare worker definitely removes fears and concerns about illness amongst patients. However, the reassurance behavior initially depends upon the practitioner qualifications, his behavior and characteristics, which in turn depends upon his specialization and understanding of spinal disorders. And even amongst doctors practicing allopathy, there may be a difference across residents, general practitioners and spine specialists. With increasing access to alternative methods of healthcare, tremendous rise in MRI prescriptions is a serious concern to be solved. So it is not uncommon to receive a patient with an MRI report highlighted with various terminologies which were actually done by the primary health care provider. Now it is a daunting task to remove the negative perception because patient has already done an internet search of MRI report, resulting in cyberchondria. That is, individuals with chronic pain often turn to internet to identify possible causes or sources of pain symptoms. Unfortunately, the term disc bulge when Google search results in such information that it can cause pain in the buttocks, it can affect your ability to walk, it can affect multiple discs, and it develops over time to cause disc degeneration and narrowing of spinal canal. Now this is worrying because the most simple term is disc bulge is oftenly used in our MRI reports, whereas the Google search reflects such a massive pathology. Our hypothesis is that by traditional MRI reports result in catastrophization. Reassurance provides benefits in these groups of patients. However, it depends upon the healthcare provider's knowledge on the subject, as many rely on MRI reports rather than the actual image and clinical severity. On alternative clinical reporting, conveying many meaningful information by avoiding derogatory terminology can improve perception of pathology amongst healthcare workers. Now, this will increase the reassurance behavior amongst the healthcare workers, enabling the patients to enter into a positive feedback loop. Henceforth, a clinical MRI report could result in improved patient outcomes and avoiding unnecessary interventions. Thank you.
Thank you, Dr. Dilip Chand Raja. That was a fantastic presentation. In fact, we will discuss this further during my talk subsequently. I would now want to welcome Ranjit KR. In fact, congratulate and compliment him for the ASSI Clinical Research Award for this year. He will present his work on all posterior approach in surgical management of thoracolumbar tuberculosis, a prospective randomized study comparing posterior only stabilization versus global reconstruction. Over to you, Ranjit.
Good morning, respected senior faculty, colleagues, and dear friends. First of all, I would like to express my sincere thanks to ASSI for giving this opportunity in presenting our research work, all posterior approach in surgical management of thoracolumbar tuberculosis, a prospective randomized study comparing posterior only stabilization versus global reconstruction. So, in spinal TB, as we all know, is primarily a disease of the anterior column. And the two primary challenges in surgical management include how to address the anterior disease and when to address this anterior defect. So the question number one, how to address the anterior disease or the approach-wise. Various approaches have been described, including the anterior, the combined approach like the anterior approach where we go simultaneous or even stage, and all posterior approach. And currently, all posterior approach is described. There have been numerous articles supporting the all posterior approach, showing its advantages, including a superior deformity correction, 100% fusion rate, and a lower complication rate. Now comes the second question, when to address this anterior defect or when to go for an anterior reconstruction. So whenever the anterior defect is big, like a multi-segmental disease, where the preoperative vertebral bone loss is more than 2 or following any correction of 30 or 40 degrees of kyphosis, we need an anterior reconstruction and there exists no controversy. But when the defect is kind of borderline, like when you have a post-segmental disease, where the preoperative vertebral bone loss is 0.5 to 1 or a preoperative kyphosis less than 30 degrees, is there really a need for an anterior reconstruction or should posterior only stabilization be adequate? So we did a thorough literature research and we found no strict guidelines in the existing literature on anterior reconstruction indications as such. And there were lack of prospective studies comparing posterior only stabilization versus global reconstruction. So we aim to evaluate the clinical, radiological, and functional outcomes of all posterior approach in the surgical management of thoracic and thoracolumbar tuberculosis. And we compare the surgical outcomes of posterior only stabilization versus global reconstruction. We did a prospective randomized study with a minimum follow-up of 2 years and included all those patients with a pre-operative vertebral bone loss in the range of 0.5 to 1, age group between 18 to 65 years, and all those surgical indications including intractable pain, neurologic deficit, deformity, or failure of conservative regimen. We excluded patients less than 18 years and more than 65 years, with those with a pre-existing deformity and histopathosis of microbiological inflammation other than tuberculosis bacteria. We randomly allocated the patient group into two groups, Group A, the posterior-only stabilization, and the Group B, the global reconstruction. And procedure-wise, the posterior-only stabilization without neurological deficit have undergone a posterior instrumentation using pedicles, screws and rods, and transpedicular debridement, limiting the debridement to an extent to prevent a significant anterior defect. Whereas those who are having a neurological deficit, we did a laminectomy along with the procedure. And in case of a global reconstruction, we did a posterior instrumentation along with a transvesical, transpedicular, or a costotransversectomy approach for the anterior reconstruction of the defect. This was our consort chart, and after our exclusion of all those dropouts, we had 29 patients each in Group A and Group B. So we collected all the demographic details, the comorbidities, the duration from onset of symptoms to surgery, the disease location, indication and duration for surgery, blood loss, levels of instrumentation, the complications, and the duration of hospital stay. And outcome measurements include the radiological, functional, and neurological. Radiological include the preoperative vertebral bone loss, the corpse angle for the kyphosis, the correction, the loss of correction, the ankle loss rate, and the fusion time. And functionally, we did the visual analog scoring and also the disability index at the preoperative and the final follow-up. And neurological assessment was done using ASIA scoring. So the clinical characteristics results showed the duration of surgery was found to be significantly lower in the Group A, that is the posterior stabilization group. However, the age and the duration of symptoms were found matching between the two groups without any statistically significant difference. And the radiological outcomes, though it was not statistically significant, the Group B, that is the global reconstruction group, showed marginally better kyphosis correction, its maintenance, and the loss of correction was also found to be lower than the Group A, where the posterior stabilization group, but the results were not statistically significant. The functional scoring, the VAS and the ODI score, the ODI score at the 2-year follow-up showed better results in the Group A when compared to the global reconstruction group. And neurological outcomes where the ASIA scoring did not show much difference between the two groups. And we also performed a subgroup analysis in the Group B, that is the global reconstruction group, where we compared the radiological outcomes using an autograft and a metallic cage, and we did not find any significant difference in the radiological outcome at the 2-year final follow-up or even post-operatively. So our results in a nutshell include the duration of surgery was found to be significantly lesser in the posterior stabilization group, and the ODS scores were also found to be better in the posterior stabilization group. Though the radiological outcome was marginally better in the Group B, that the global reconstruction group, it was not found to be statistically significant. And the metallic cage versus autograft did not show any difference in the radiological outcome, which we did a subgroup analysis of global reconstruction group. Of course, we had some limitations like the thoracic and thoracolumbar spine patients are only included, so that there is some difference in the biomechanics in case of deformity correction as well as the deformity maintenance. And we had a smaller sample size and shorter follow-up period of 2 years. So to conclude, all posterior approach is an effective approach in the management of TB affecting thoracic and the thoracolumbar vertebra. The surgical outcome following posterior stabilization is as effective as the global reconstruction group when the preoperative vertebral bone loss is in the range of 0.5 to 1. And the autograft and metallic cage found to be equally efficacious in anterior reconstruction as far as the radiological outcomes are concerned. So here are some case examples where a 38-year-old female with a T70X spondylolisthesis is managed by posterior stabilization, and we had an ankle correction of 7 degrees and a loss of correction of 2 degrees at the final follow-up of 2 years. And a 42-year-old male with a T10 spondylolisthesis managed by global reconstruction through all posterior approach had a correction of 8 degrees and a loss of correction at 2 degrees at the final follow-up. I thank you for the patient listening.
Many thanks, Dr. Ranjit, for a lovely presentation and very interesting work. We now move on to the next part, and that is the ASSI Publication Award. ASSI started the Publication Award in order to encourage our society members to publish more, to do more research, publish more, and come out with more answers. And I think whatever be the reason, whether it is this award, whether it is more youngsters doing more work, but the amount of research which is coming out of India this year has been fabulous. Is this the COVID effect? And that we hope not. We hope that these numbers keep on rising with year after year. We have a number of youngsters who have given competition to our seniors, Dr. Rajsekharan and Dr. Chabra, who invariably win this award every year. We have Dr. Bhavuk Garg, Dr. Vishal Kundani, who have come up with 20 plus free papers in the last year. But in spite of all these efforts, there is only one person who had papers which enumerated to 46, and most of these were in journals which were high impact journals. And therefore, without doubt, without any controversy, without any argument, the award goes to none other than Professor S. Rajasekharan for his extremely hardworking and extremely fantastic research profile. Dr. Rajasekharan, a couple of words from you for the youngsters watching. What motivates you to continue performing at this level when you are so busy clinically, you are so busy managing work in the hospital, and there is so much else to do, and yet you are able to come up with so much work year after year? Please enlighten and give us a message of how we should proceed.
So, Gautam, thank you. I thought you said no questions, but you have asked a question, so I would answer. So, when you are working very hard, there is something called professional fatigue. And people succumb to it after some time. They say, I've been working hard, now I need rest. But one of the best methods by which you can overcome professional fatigue is by doing research on what you're doing, because it keeps your mind active throughout the day. Every single patient that you see actually ignites a question in you. And when you're actually looking at beyond treating him and asking important questions like what causes this problem, can it be prevented, what is happening at the molecular level, your mind is always ignited, and it keeps your work interesting. I think the research is for knowledge, but also it is for yourself. The second thing is, just one more sentence. The second thing is, it's not, research is not one person's work. It can never be. And it's the effect of a whole team. And now we have gradually expanded our huge research team. And that is the essentiality of success. Thank you, Gautam. I'm really proud about this.
Thank you very much, Dr. Rajsekharan, and we congratulate you for your excellent work, sir. Moving to the traveling fellowships, this year we are awarding 2 youngsters a traveling fellowship. The 2 youngsters are Dr. Jwalant Mehta and Dr. Kondeti Sri Krishna Chaitanya. Both of them are over here. I congratulate both of you for the excellent work that both of you have been doing over the last couple of years, which has culminated in you receiving this award. I hope that you will, with this traveling fellowship, you will visit centers away from the primary centers that you have trained in, learn from different mentors, see different kind of work, and that will broaden your horizon and improve your ability and to think out of the box. So congratulations again from the entire ASSI, from President Chabra, myself, and the executive committee for winning this award. We now move on to the report of the ASSI Research Grant Award. And the first report comes from none other than our president, Dr. Chabra, who will be giving a report on his paper, Transforaminal Selective Nerve Root Block Using Steroids versus Platelet-Rich Plasma in Prolapsed Lumbar Intervertebral Disc with Radiculopathy, a randomized double-controlled trial. Can we have Dr. Chabra's presentation, please?
Thank you for giving me the opportunity to present our work on transforaminal selective nerve root block using steroid versus platelet-rich plasma in prolapsed lumbar intervertebral disc with radiculopathy, a randomized double-blind trial. Let's start with a couple of case studies. A 32-year-old female, severe radicular pain in left lower limb for 2 weeks, VAS of 8, ODI 86, no neurological deficit, and no relief with conservative management, including oral steroids. Another similar case study of a 36-year-old male with similar severe symptoms not responding to conservative management. What would be our options in managing these cases? We know that the pain generators for such pain are mechanical compression and chemical irritation of the nerve root. And this opens the scope for selective nerve root block by blocking the chemical irritation of the nerve root. We have various options, including steroids, etanercept, local anesthetics, hyaluronate, and platelet-rich plasma. The PRP contains 150,000 to 300,000 platelets per microliter, contains 1,100 proteins, including multiple growth factors, contains anti-inflammatory cytokines, and has been widely used in patients with orthopedic conditions with success. With regard to preclinical evidence, there is ample evidence, and this review concluded that all the included studies underlined the positive histological results, demonstrating that PRP induces ECM regeneration and cell proliferation. With regard to clinical evidence on platelet-rich plasma for treatment of discogenic low back pain, there is enough evidence in this regard also. And in this case study, which was published even in a pregnant female where PRP was used, after multiple steroid injections had failed and pain had worsened after she became pregnant, it was found that PRP was effective even at 1 week after follow-up.
Did we lose signal?
Well, you know what was interesting was that we are running about 10-15 minutes early, so this gives us an opportunity to catch back on time and not finish the session too early. So that was why it was stopped. Now we can continue again.
Low back pain, there is enough evidence in this regard also. And in this case study, which was published even in a pregnant female where PRP was used, after multiple steroid injections had failed and pain had worsened after she became pregnant, it was found that PRP was effective even at 1 week after follow-up, and the effect was sustained. So we decided to conduct a study on the efficacy of PRP versus steroid administered via transforaminal route in prolapsed lumbar interval disc with radiculopathy and assess the clinical outcome by visual analog score, ODI, and SF12. It was a prospective randomized double-blind intervention study, and all patients diagnosed to have lower lumbar disc herniation with radiculopathy which visited our center were included in the study. The sample size estimation revealed that 23 patients should be there in each group, and all such patients with lumbar PIVD defined clinically by radicular pain in lower limbs, positive SLR, not responding to conservative treatment, and correlated radiologically by findings of lumbar disc herniation or prolapse in recent MRI were included. Of course, there were a host of exclusion criteria, including pseudoradicular pain, red flags, and previous surgeries. Under sterile conditions in the operation theatre, 30 ml of blood was withdrawn from the patient and processed in the Harvest Smart Prep 2 machine to generate 3 to 5 ml of PRP in 15 minutes and then subsequently injected in epidural space in sterile conditions. Participants were allocated to either the steroid group or PRP group using lottery method of randomization. After informed consent and under aseptic conditions, using a spinal needle of 22 gauge and under fluoroscopic guidance, Omnipec was injected to identify the pathological site. And then after injecting 0.5 cc of 0.5% bupivacaine, either 1 cc of steroid was injected or 2 cc of PRP was injected. Root block was considered positive if there was more than a 75% decrease in pain compared to pre-injection status. VAS, ODI and SF12 scores were documented at baseline and at 1, 3 and 6 weeks after the injection. Statistical analysis was done by performing Mann-Whitney U-test. You can see the results here. And the pre-injection, both the groups were comparable except mild difference in SF12 scores. 1 week comparison between the groups, PRP and steroid, showed that a greater improvement was there in VAS, ODI and SF12 scores in the steroid group. However, at 3 weeks, PRP group showed improvement, and at 6 weeks again, the PRP group showed better results. And we monitored all these outcome measures at various follow-up time periods. In all patients of both groups, there were no complications during the period after the injection. So PRP has pro-inflammatory properties in initial few hours, and many growth factors are released after many days. Both the groups showed significant improvement in pain after the procedure. There was statistically significant improvement in functional outcome in both the groups on follow-up till 6 weeks. At 1 week on follow-up, the steroid group had better results compared to PRP. At 3 weeks, outcomes were comparable, but at 6 weeks, PRP had better functional improvement. So we could say that PRP is safe and multiple injections can be given if required, even though we use single injection in this pilot study. And PRP does not provide relief in acute pain. Hence, we should remember to supplement with analgesics. Of course, like other studies, there were limitations of the study. It was a small group of subjects. 23 subjects were required in each group as per sample size estimation. However, due to the pandemic, we could recruit only 14 subjects in each group. And there was a short follow-up period. But taking this as a pilot study, we can take this forward. So the take-home message would be transforaminal selective nerve root injection is a good treatment option for uncomplicated radicular pain. Autologous PRP has already been established as standard of care in many orthopedic conditions. There are promising results of autologous PRP in management of PIVD as well. Improvement occurs gradually but lasts longer. Future studies are warranted to determine the best candidates for this treatment, the optimal injectate, and the relationships between patient-reported outcomes and radiological findings. Thank you to ASSI for giving us the opportunity to conduct the study and sponsoring it. Thanks. I would welcome any questions. The next presentation is
by Dr. Rajshekar.
By Dr. Rajshekar, investigating the pathogenesis of adolescent idiopathic scoliosis and the influence of mechanical loading on scoliotic disc, a proteomic analysis. Can we play his presentation, please?
Good morning. I would like to thank the ASSI for giving us the opportunity to do this research work, and I would like to share our work on behalf of all our team members. None of our team members have any disclosures. Now, the genetic basis of idiopathic scoliosis is strongly associated with genes, and you can see a lot number of genes have been implicated in the etiology of scoliosis. However, most of these are association studies, and there is no direct proof of the protein disturbance that they cause in scoliosis, and so there are many unanswered questions. Now we know that proteins are the language by which genes cause their effect in the body. But a protein analysis of the disc in scoliosis have not been done. Now, this may be important because the notochord with its membranous sheath is the earliest form of spinal column. And we know that many studies have noted changes in the ultrastructure of tissues in scoliosis. So to look at the proteomic analysis of scoliotic disc may reveal a lot of clues. Now, this was done in Ganga Hospital and Ganga Research Center. And the materials for the study comprised of 8 scoliotic discs obtained from anterior surgery. And this was compared with controls, which was 8 normal discs obtained from brain-dead voluntary organ donors. Now, the proteomic workflow is something that was internationally accepted. And at the end of the study, we found 1,094 proteins in the normal disc and 1,585 proteins in the scoliotic disc. Now, interestingly, there was an upregulation, which means there was an increase in many of the proteins which are controlled by the genes which have been implicated in scoliosis. Collagen 9A1, matrilin, osteonectin, procollagen C proteinase enhancer, NTF3, calcium binding proteins, and Wnt proteins. All of them were found to be upregulated. And contrarily, GDF5, neuregulin, COMP, and FRZP. These were important proteins which were found to be downregulated in the scoliotic discs. Now, why is this important? Now, there are a lot of implications of different hypotheses in scoliosis: genetic, hormonal, asymmetric growth, biomechanical theories, neuroosseous theories, disturbances in equilibrium and proprioception, osteopenia, and deficiency of melatonin. Now, all these have not been proved with a protein analysis. Our study actually found a disturbance of many of the proteins which have a connection with the genes which were already been implicated. For example, matrilin and procollagen C proteinase enhancer. Both of them were found to be upregulated, and we know that they form an important part in the organization of the chondrocyte, and the disturbance of these could lead to scoliosis and also the collagen fibril morphology. Now, we found a disturbance in both of these. Similarly, neurotrophin 3 and COCH. Now, both of these are associated with postural equilibrium. And there has been proof and publications which have implicated these polymorphism of these in scoliosis. And we did find that they were upregulated in our studies. Vitamin D3 deficiency and osteopenia has also been implicated of late. And we found COMP, which plays an important role in bone growth, and mutations of which have been known to lead to skeletal dysplasia. And also there was a downregulation of TGF6 in our study. So this shows that these are important proteins which have a problem in scoliosis. Similarly, asymmetry in paraspinal muscles has been proposed to have a role. And we know that the MEGF11, which is a myoblast regulator and which has an important role in myogenesis. And we found that to be upregulated in the scoliosis group. There is also a problem of dysmorphogenesis, proteins which are concerned with normal morphology, and growth differentiation factor 5, a member of the BMP family, which plays an important role in growth and development of bone and cartilage. We found it to be downregulated in GDF. So our study actually showed for the first time that the disc in scoliosis has many differences in its protein content at molecular level. And many of these differences can also be implicated and related to many of the genetic associations which have been reported earlier. Although this is of a small sample size, our study confirmed the presence of many protein abnormalities in genetic studies, and we were also able to identify many new proteins disturbances, and these proteins are involved in embryogenesis, bone cartilage growth, calcium binding proteins, neurotrophic factors, Wnt signaling, and all these have a potential role in the etiopathogenesis of scoliosis. From the existing evidence, it looks to be multifactorial, and I think it is safe to conclude that scoliosis occurs in genetically predisposed individuals, possibly with an epigenetic influence. This study will have more value when it is validated in a large sample size. So I would like to again thank the ASSI for giving us this opportunity on behalf of all my team members, and thank you very much.
Thank you, Dr. Rajsekharan. That brings us to the end of the ASSI Clinical Award session. And we now move on to our next session. We are a little early. We are about 10 minutes early with finishing this session and have the opportunity to wait and if so, ask some questions to the award winning, which is not normally the case. But in this case, we have some time and we can afford to do it. So if any of the panelists or the audience has any questions for any of the award winners, please go ahead. Dr. VTI, any questions regarding the platelet-rich plasma paper that was there? Please unmute yourself.
I congratulate Dr. Chabra for his presentation. How easily do the patients accept that their blood will be taken and injected?
So that is not an issue because we only take 30 ml of blood. We have to let them know that again this was an experimental study and there is evidence, but there is no confirmatory evidence in that regard. So that was the main limitation. The other main limitation is the expense that comes with processing the blood to get the platelet-rich plasma. So the consumables are expensive. Normally it would cost around 40,000. So whereas the steroid comes very cheap. So that is the question, but we have to look at long-term results and see whether PRP has a better result than steroid, which is right now the gold standard for this.
What does the literature say? What are the long-term studies available on PRP?
Sir, not very long-term studies, but there are enough studies with other orthopedic conditions which reveal good outcomes long-term as well. And they have been used in a host of conditions, but many times I would acknowledge that it is being arbitrarily used here and there, but it has special indications where it has delivered better, especially because of the various cytokines and the growth factors which are there. And especially when there are costochondral defects, it has shown to have a good result.
We do have experience that the steroid injections in certain patients work for 8 years, 10 years, even when their radiological appearances deteriorate, but clinically they are still doing okay.
True, sir.
So I'm not sure. Of course, over a period of time, the mass will gather together. But as on today, we are not unhappy with steroid injections.
Agree, sir, that still continues to remain the gold standard till we can prove that this is
certainly
long term, sir. So it is still experimental. That's what.
And that cost part of the story is an important issue. So the moment you tell patient that we'll give you costly injections, they're not willing. They'll spend for the surgery 40,000. But for an injection, they'll not spend 40,000.
But the other thing is that many people either do not know anything about steroids or they know too much about steroids. So the moment you say steroid,
they know only bad thing.
40 milligram. Many of them will say, Don't you get used to the steroids if we inject?
But convincing that is easier, Convincing that is easier.
With their own blood concentrate which would be injected, sometimes they agree to it.
There are some more questions from Dr. Jaiswal, then Dr. Basu, and Dr. Srivastav in that order.
Raja?
Yeah.
Are you there? Great work. You're progressing fantastically on the genetic basis of spinal disorders and continuing on into SCOLI. Great initiation. A couple of educational tips to me, right? Now, earlier the genetic basis of AIS, which was being looked at, was internationally, and Ogilvy had done a lot of work on this, was on samples from blood, genetics analysis from blood, right? You're looking at discs in SCOLI. Understandably, your basic infrastructure is on disc. The disc, as I understand, are the secondary effect of a SCOLI. So what made you choose discs? Of course, you have got the infrastructure for your disc work. Why not? Why didn't you look at the bone, for quantification and genetic basis when you get taking samples?
Yeah. So Arvind, thank you for this question. So the genetic studies are both from the blood and from saliva. And these are all association studies. I mean, they are associating the presence of genes with the incidence of scoliosis. So it's not foolproof. But we all know that genes act through alterations in proteins. And there are a host of genes which have been implicated. And multiple areas of these genes are somehow acting on collagen. Some genes are responsible for the formation of proteoglycans. Some genes are even for development of muscles. And some of these genes which are implicated out for postural balances, everything. But there have been only associated studies, no proof of what is the protein alteration that they are creating in the spine. So that's what we wanted to make sure to demonstrate the end effect of these genetic differences, and we have been able to prove that, and that was it. What is important in this is some of these changes may also act as biomarkers. And so rather than just taking a saliva test, maybe we can identify these in the blood, then this will be useful. You also asked the right question, why we took up as disc. We are actually looking at the annulus also. Bone, I am not so sure. We are looking at the end plate because that is the growth responsible. So we are looking both at the end plate and also the annulus separately.
And
so probably next year you will hear about it.
Oh, great. Would suggest also to look at the muscles from convex and concave side, and of course, rightly pointed, and end plate would probably be more thing, and a sample from the bone. Actually, there may be genetic changes in the bone itself, the vertebrae itself. Yeah. Great.
Yeah, like he said, from the left and right side of the muscles. I don't know whether the convex side, the nuclear part, and the concave side nuclear part would have any differentiation in their genetic content, protein content.
No, sir, because the changes in the convex and concave part will not have any change in the genetic content. The genetic content is the same for the whole of the body. But if you look at molecular changes and changes in the collagen proteoglycans, there is a difference between the concave and convex side, but that is secondary to the mechanical effects of compression and distraction.
And it's not dictated by these presence of these histochemical differences.
It is not genetic, it is only due to secondary effects of mechanical compression and distraction. We have actually done a very, very thorough study on this, and that was given the Easels Award about 10 years ago, actually. So the differences between the convex and the concave side and how distraction and compression cause changes. But that is not genetically influenced.
Dr. Basu?
Thanks, Gautam. My question is to Dr. Chhabra. understanding that this degeneration and collapse has its own natural history, how would you really differentiate between the pain response due to natural history versus the pain response due to modulation which you're doing by either injecting steroids or PRP?
Agree, Swamijit. There is a natural history, but we generally give these injections only to people who have a failed conservative trial and in which the pain is affecting their activities of daily living. So it would be also, you could have a trial where you don't do anything and you do an intervention, but that may not be ethical since steroids have proven the test of time. There are ample number of studies. There are books, in fact, which show the efficacy of steroid in reducing the chances of surgery. These are given in patients who would otherwise proceed to surgery, and it has been shown that 3 epidural selective nerve root blocks can reduce the incidence of surgery by as much as 60% in these patients. So, since we are comparing with the gold standard, I want to mention that there is no case series also for PRP in disc prolapse, even though there are some studies for back pain specifically. So this was the first case series, and we hope that it will be published and we should be able to then proceed further. This is just as a pilot where we gave only one PRP injection to test the safety and efficacy. We could do a bigger trial, but as I mentioned, the costs are a limitation.
You could have a control group without any intervention.
Yeah, but those are people who have severe pain and it is affecting their quality of life.
For example, you're not stopping pregabs and analgesics for those patients who have undergone a PRP or a steroid injection, versus a conservative group which doesn't have any intervention but has those pregabs and analgesics. Could be a sort of...
Agree. I will be presenting later also where I will throw more light in this regard. We have done a study which has been submitted to the spine for publication on that as well. But epidural steroids there has been a control group where they have shown better results. So we are comparing against something which is an established gold standard, right?
Right. Dr. Rajendran, your response to the now famous Australian disc trial, which has a very long, arduous trial with multiple hospitals involved, which say categorically that degenerate disc has nothing to do with infection.
Oh, yeah. So, the whole of the spine community is divided deep into believers and non-believers of subclinical infection. And the issue is, how are you identifying the bacteria? Now, if you are depending on the culture media, which is known to be culturing only our known set of pathogens, then you are not identifying many of the bacteria which is there. That is the central problem with them. Now, all these bacteria which we are trying to identify by NGS, they don't have any known culture media which will grow them. So if you're doing a big trial and if you're trying to identify a terrorist and you don't even know his name and his face and his identity and where he is, and you just look at only your known places and then say there is nobody there, it's not correct. It is going to be a game changer if you start looking at it. I am 100% sure even what we are saying as aseptic discitis, all of them are septic discitis, but they are from organisms which we don't know.
Can I ask?
Yes, Dr. Srivastav, last question before we move on to the next session.
Dr. Chhabra, very nice paper. I just wanted to, add to one thing, that if you create another group where apart from analgesics, which you are giving to even the rich plasma patient also, why not to just inject saline to make a proper control group? Yeah, so that the needling is being done in all three, but the material is different.
So I agree, sir. That is a good suggestion. But the only thing is they have found saline also to be effective because it tends to remove the adhesions. It works by adenolysis. So
no, Chabra, it doesn't. The saline injection does not release adhesions. The saline leaks out from 100 apertures in the spine. So it doesn't produce any pressure, epidural pressure whatsoever. It never does. It has been believed long ago. See, the adhesions, you use instruments and tear them or cut them or snip them, burn them. You need such a mechanical device. How can a water fluid, which is not even going beyond a particular pressure, can do adhesivolysis? It doesn't. We have tried this on the table at various places. It doesn't.
Gautam, can you, just like subclinical infection has believers and non-believers, you will see that PRP also has strong believers and non-believers.
Sir, we'll stop here. We have to move on to the next session, which is a very important session. Thank you all for such a lively discussion and good research papers. Congratulations, Dr. Rajshekharan, as always. Dr. Chabra, please take over. This will be the first session will be a presidential guest oration followed by the presidential oration by Dr. Chabra himself. So Dr. Chabra will chair the first session along with Dr. Raghav Dutt. Dr. Chabra, please introduce the guest, please.
Yeah, can you see my slides?
Yeah, yes, we can see.
I saw that now.
Thank you. It is my pleasure and honor to introduce Associate Professor Douglas Brown.
Thank you.
He has been like my mentor, so it is my pleasure to introduce him. He is the former director of the Victorian Spinal Cord Service, a comprehensive traumatic spinal cord service at Austin Health. He is a graduate of Monash University. He became head of the Spinal Cord Service in 1982. He is the founding director of the Spinal Research Institute, Heidelberg, Victoria, Australia, and currently its executive director. And very importantly, he is the past president of ISCOS from 2012 to 2014, and have had the pleasure and honor of working under him and with him for a very long duration. In 2012, he had been an author or co-author in 84 papers published in various journals and 4 book chapters. This would have been added subsequently. His current research interests are the peripheral organ consequences of spinal cord injury, physical and psychosocial aspects of SCI rehabilitation and community reintegration. He has 40 years experience in the management of spinal cord injury, and very recently, he has been bestowed the honor of the Member of the Order of Australia in the Australia Day 2021 honors list for significant service to medicine, particularly to spinal cord injuries. Hence, it is my proud privilege to be able to introduce my mentor, Professor Douglas Brown, whom I thought would be appropriate to deliver this lecture. Can we play his talk, please?
My name is Doug Brown. I'm the Executive Director of the Spinal Research Institute and previously Director of the Victorian Spinal Cord Service in Melbourne, Australia. We're going to talk today about the translation of spinal cord injury research into clinical practice. As you know, this is a complex and difficult topic and is not well covered, with no real plans or strategies to effect such translation, and we're going to talk about what needs to be done or could be done. Part of the problem is that there is an enormous amount of research that's published every year, and this is just a very unsophisticated login of topics to Google Scholar over 10 years. Some of the papers there are obviously coming up several times, but the slide does give you an indication of the vast amount of publications that there are, and sifting and trying to get the knowledge and whatnot is very difficult because you can't read all those papers in 10 years, even if you divide that by 10. It's a lot of papers, and they're not always relevant to whatever we have an interest in our own clinical practice. So there is such a lot of research, but we'll find the changes in clinical practice are really quite slow. And it's been well reported they take up to 17 years and commonly 9 to 12 years. That's a long time. And by the time you're getting the research into practice, the world has moved on. So it makes it difficult. And it also means that patients aren't getting the advantage of the latest research. So why does it take so long? There are a lot of reasons, and it's a very complex situation. Healthcare and healthcare systems are large and extremely complicated. The healthcare is probably the most complicated industry in the world, certainly one of the most complicated. There are so many, if you like, products in all the diseases, but really the main focus is the patient, and the patient carries every complication, every possibility, every metabolic combination you can imagine. So this size and complexity carries great inertia with it, and that makes change slow. But also healthcare competes at a government level with other governmental priorities for funding. And sometimes they seem to be more important than the healthcare research and the application of that to clinical practice. And the research volume that there is out there doesn't equate to relevance or quality. And so it really is a difficult situation. But clearly in governmental terms, the urgent is going to replace the important because the urgent is within the timeframes they work. The other factors that have an impact are political and personal factors. These definitely influence health priorities and health practice. People are not purely focused on what's the right thing, what's the logical thing, what's the sensible thing. It's difficult to make decisions in complex situations, and the personalities are the ones that really understand and drive change or not. In democratic societies like ours, the public perception of health needs can be very important in influencing government and hospitals about priorities, because they end up then with sometimes what's the biggest problem, as it were, has the most influence. And yet sometimes the more important problem in a strategic sense with terms of economics and that isn't so obvious, it's not so numerous, doesn't get the attention. And the other factor that we need to always to remember is that we're moving in societal relationships, and the age of professionals is now replaced by the age of managers. Some people disparagingly call them bean counters, but they are people who look at things from a different perspective with an eye to the cost and trying to get costs down while maintaining standards, rather than costs down by increasing standards of care, which are often more cost effective. The other factor that we need to always be aware is that there is poor public and political education, and therefore the public and the politicians that can't really make good assessments of research outcomes. And that's why it's important that doctors be part of it, and professionals be part of it, even though it's the age of the managers. We also need to be aware that there is often very poor presentation of clinical research results, and many of them presented as if there's magic in them and the answer is there, it'll be there tomorrow, when in fact they haven't gone that far, but they need to sound positive in order to get the next grant. There is therefore a very big break in the research continuum. There's the basic research in laboratories and so on, and that needs to be translated into clinical trials. And then when the clinical trials are completed, stage 1, 2, 3, there's an implementation to practice. Now, there are often breaks in that continuum. There are breaks after the first pilot studies when the study doesn't go on to be big enough to become significant. There's a big break when there is a significant result from that moment to putting it into practice. So the research is done, it's published, and the research moves on, but the outcomes may not come into practice. So how many people know of that research, for example? How many have read the paper when it was published? Was it in a journal they read? How many go to the conference where the paper was presented? And there's so many conferences as well, which I didn't mention before. So new knowledge dissemination is quite slow. It may even not go far. It may stop where it starts, in the unit where the technique was developed, but there is no financial incentive to go forward. It may be forgotten and perhaps rediscovered years later. That's quite important, quite common. And the other real thing is, who champions the change? Who champions the new research outcome? And is it someone that's got some influence? It won't go far. So it's fast in the situation where there's commercial input. So drug companies and device companies develop their product. It takes them some time. They do some research, going through the clinical trials because they've got the money to do it, and they put the money into the development. And then they have to make sure that that outcome, which is good or looks good, makes a profit. So that means they must sell whatever they've produced. And therefore, they put money into marketing and education about the product. And therefore, the implication can be speeded to 3 to 5 years. And we know that the markets that are most profitable get the most marketing and education. So that means that group of commercial interest research has a relatively fast translation into practice. When the knowledge is translated fast, it's where clinicians learn the techniques with all the nuances so they can be confident in practice. That's where the marketing and education comes in. When they know how to use the new device, when clinicians know how to use the treatment appropriate to their practice, and when there is a reputable clinician championing the implementation. Most people come on board if someone they trust and believe knows what they're talking about and is experienced, says this is the way to go. So non-commercial research, on the other hand, even if it looks significant, may not even get past the pilot stage. Funding is very discontinuous, and funding of researchers in the more public sector is you have to have the results to get the next grant. So if you're doing the study, you haven't got the results to apply for the next grant, then you're writing them up, but you haven't got a grant, you've run out of money. So it's a very big problem. Laboratory research often doesn't go to clinical trial, and pilot studies therefore don't go through to the definitive 3 stages of clinical trials. Even when there is a statistically significant outcome, there is no committed funding for knowledge dissemination and implementation into clinical practice. This is really what slows down the translation of non-commercial research into practice. The things that will change this is what we need to be focusing on a little bit. The studies where there is a health and an economic benefit are the ones that are able to attract implementation support, knowledge translation from that result into practice. The economic result attracts people's attention. Health research that doesn't show benefits economically, only clinically, has a much bigger problem in getting implementation. And that often requires support outside the medical profession. So support from consumers and users, media support, and personal interest of someone who has the power to champion the change and gain priority with the funders. Researchers therefore get the best results in this area when they are allied with consumers. It's consumers who understand the research, and such an alliance can therefore be successful in making change happening, enforcing change, because funders listen to their constituents. What's going to change the current situation? That collaboration, that alliance of researchers, consumers, clinicians and funders creates an understanding of common goals and benefits. And that, everyone then owns the change. And that can enable a more rapid rollout of the research outcomes to clinical practice. The implementation is quicker when all the stakeholders are winners and then the community benefits. There are other barriers that need to be overcome. It's not just as simple as that, of course. Clinicians may be very comfortable and satisfied with what they're doing now, and really to make the change can be difficult. Change is often resisted. People often have to have a stick as well as a carrot to change. People often are not, they're too busy to take on a new challenge. You know the sort of situation I'm talking about. There's a comfort in following what someone else has trailblazed, what the leader's done in the field, and then you follow on. And if there's any difficulties, they're dealing with them, you're just a follower. And a number of clinicians can't afford, particularly with their devices or surgical techniques, can't afford to leave their private practice, because then when they're not providing the service, the practice tends to shrink. And so they can't spend much time learning new techniques and treatments. The other one is that the hospitals and the healthcare systems may not provide the funding or the leave to enable people to go and learn new skills. Therefore, the information about the commercial advantages may not be well known in and the economic advantages, and therefore they're not convincing, and that's hard to get people to understand things that are not presented in language they understand, in a context they understand, and in a way where they see that they can be part of the outcome. So the dissemination barrier, there are many publications. How does one keep up with the number of papers, and how does one know which is the best and which one will last? Some of those, them should be last, not latest. Who can see what will last and what will not progress, and what are the benefits that people have to find out about? And no one has the time to read all this. There is a need to bring research to clinical practice. Who else needs the training besides the medical practitioner? Do you need to have a team? Do you need to train nurses or physios and other people? The team concept is often not well understood or practiced, particularly in surgical areas. Becoming better, as you know. But who has the responsibility also for the change, and where is the money coming from to finance the dissemination process and the training? So shortening the knowledge translation time is a joint responsibility. Clinicians are probably the most important people in that. So they have to take charge personally. They really understand it best. They're the best trained. They have the best understanding of how it will work. Consumers can drive the change because they have influence with funders. And the health policymakers must approve the change, and they can be persuaded not so much or not only by science, but by the consumer pressure. So we also need to have health boards and government health departments involved and committed in order to fund it. And we must also make sure the hospitals are adapted and ready for change, ready to change their systems to allow new treatments to become the standard. There are some issues, but with working together, the stakeholders can move quite quickly to implement and adopt new non-commercial advances in medical research. They can do it as quickly as commercial companies. These ones we're talking about, these orphan device discoveries, are usually small in number of people using them, or in areas where there isn't the perception of importance. But often dealing with things other than cancer, for example, hip replacements, as you all know, can make people very functional. But cancer would get the money often instead of the hip replacements. We all know that. So we need to look, if 17 years for implementation from outcome to practice is too long, is 3 years too short? Well, there's a cost of doing business, which it comes about because the trial period, even for commercial companies, is quite short. You're looking at 1 year results, very rarely 3. And the longer term results are after it's been used for some time around the world or on a large scale. And the complication rates and so on become apparent, the longer term ones. And we know of examples where that has led to a device being taken off the market with those chromium hips and drugs where the anti-inflammatory action has cardiac complications years later. COVID vaccines are an example of this. They're very extreme. They're coming into play very early, and they certainly haven't got any long-term efficacy effects and complication rates known. So that will become apparent, and that's a cost of doing business. It's the complications, the compensation, and so on. That's something that's built into the business model of commercial companies. They expect failures and returns and breakdowns and unknown complications, and they have the compensation is modeled into their economics of the device or the drug. But the return on investment for them must outweigh the cost of the complications, and sometimes that means that something that is beneficial doesn't go ahead because of the possibility that there might be problems and the market is too small. The risk of the rapid implementation now, for the non-commercial ones is that much may not go ahead at all. It may be that clinicians and researchers risk their own reputations and that because they believe in the drug. Risky, of course. And the best option is to have it taken up by a commercial entity. So we are therefore in a position of what is the best, how fast should translation to clinical practice be from a result that looks like it's working. And so I think it would be reasonable to think that 3 to 5 years would be a kind of compromise that we should be looking at for good rapid implementation. So the future, to have a short implementation time, commercial drugs and devices, they will cover the cost of compensation if there are complications, disasters, and it's withdrawn from the market. But increasingly, the regulators, clinicians, and funders will also be sued because they will be, there's a legal spreading the blame kind of thing. If you don't get it from one, you might get it from the other. And that's why medical defence and all these things are part of it. And it's going to become more common that if clinicians are using drugs and devices that only have a 3-year or whatever trial period, they may find that they'll get off because they haven't done any harm or they haven't done anything intentionally, but they will still be troubled greatly. And sometimes, if they've been promoting the device for the drug company or the device company, they will be implicated with that commercial company. So in the shorter time frame for the non-common, non-commercial or orphan devices and drugs, that's an interesting area too. This now is the age, not so much of the managers, but also now the common person. The common man now has a bigger say. And you in India know very well how that has played out in recent times with farmers in Delhi. People can have really big impacts politically. And that's going to have an impact on how complications are dealt with. So this will lead to more actions against clinicians as well as regulators, universities, hospitals and companies. This is something that we all need to be very aware of. So how should the clinician prepare for this? Because it's happening. So every drug device and every drug and device that is used, that's come on the market in the last few years, and you're starting to use it, you must keep very careful clinical notes because we know that if it's been around less than 10 years, it might be that 5, 6, 7, 8 years, the complication will suddenly, people start to count them up and find that it's been quite common. People have been ignoring it. That won't be acceptable. Clinicians must feel that all drugs and all devices that are less than 10 years in use are in a sort of phase 4 trial and that they're the clinicians participating in that trial. Very important to keep your notes up to date. Very important to highlight complications. Also, any other diseases or complications that your patients get, because that's how the cardiac complications of some drugs have come up not because the drug has been targeted at the heart or the cardiovascular system, but because there's been increased incidence of strokes or heart attacks. So it's very important to make a note of that for each of your patients and see how that goes, and even to be able to present some of those at results at clinical meetings. So the other factor, of course, it's absolutely important that any complication that might remotely be related, remotely even, needs to be reported, because that's when the data can be assembled to see if there appears to be any association. So it's important in this age where the people are so much better educated, have so much more social mobility, social connection, and so on, that they be active stakeholders in the implementation of all new drugs and devices. So it's important for clinicians to acknowledge that their patients are really partners in this phase 4 drug trial as you prescribe treatment and undertake surgery to install devices. It won't be good enough to have tokenism. I've discussed with the patient, I've told him that the patient has to be really very much part of the process. They need education, and not just for one particular device or drug, but really it should be part of the system. So therefore, the clinicians have to accept their leadership role as a serious responsibility in the implementation in the period of up to 10 years from the time the drug or device hits the market. They are actually, and you are actually, the key people in how that drug is translated into practice, and whether it stays, whether it is its place is defined, will only come with time. The short-term phase 3 trials are not going to give us the longer-term outcomes.
Thank you, Dr. Douglas Brown. That was a wonderful presentation. I think, can I request you to brief all the participants about the activities of Spinal Research Institute, what you are doing to promote research, and what would your tips be to young clinicians and young spine surgeons on how they could incorporate research in their day-to-day activities?
Thank you. This is a big question. The Spinal Research Institute recognises that a lot of research that has outcomes that look promising aren't being implemented very quickly because the mechanisms for dissemination of information about the device or the drug are so poor. And so its role is to try and develop collaborations between people, networks around the world that will bring information to people's attention even when they don't go to the conference or read the paper. And that's its major focus, particularly focusing on younger clinicians and younger researchers, and also looking to help the consumers, the patients, understand what their role can be. Because I think it's very important in the future that we work together to get the answers. Being researchers in a little academic bubble where we don't talk to other people, we don't share information, creates a situation where when the research is done, there is no outreach that is really developed. So networks, I think, are very important. And the Spinal Research Institute is very keen to develop networks of people with common interests. And that in spinal cord injury, that involves people from all disciplines of medicine. Surgeons, critical in the acute phase, because the management of the vertebral column is also the management of the cord. And later situations where non-trauma, where people have stenoses and tumours and that, management of the vertebral column is management of the cord. So spinal surgeons are actually critical spinal cord surgeons. And the structure of the vertebral column, the mechanics, is really only part of the the surgeon's job. So he needs to be involved with people working in spinal cord injury to work together with them so that we get the best outcomes. It's really, we don't want the situation of, the surgery was a success, but the patient didn't benefit. We really want to have the very best possible outcome. So working together is very important. In spinal cord injury, this also, in the chronic sense, involves physicians in respiratory medicine, cardiology, and involves urologists, plastic surgeons, etc. But in terms of us today, it's the vertebral column surgeons are looking after their neurosurgeons as well, if you like. They're looking after the cord. The neurology of the cord is really what it's about. The vertebral column is to protect the cord and to provide the strength and the flexibility for the cord. So I think we're really very keen to develop collaborations. We're particularly keen to bring young researchers into contact with young researchers, to bring clinicians in contact with researchers, people with spinal cord injury and their carers and loved ones in contact with researchers, so that for the future, not just the people with spinal cord injury today, but the people who will have accidents, who will have tumours, will have stenoses and so on, will also get the very best outcomes. And so anyone who's prepared to work with us on that is very welcome. We're the Spinal Cord Research Hub, Spinal Cord Research Hub, SCORH, is there for everyone to use, to form groups, to form collaborations, to develop protocols in the wider collaborative sense, and to come forward with multi-centre studies to give us outcomes that really change things with a lot of power behind that, because they'll have the outcome, we'll have the consumers who are there, who are going to benefit and see the benefit and have the power, and the clinicians in that who will implement it, and then we can really influence funders for the implementation of change that will benefit everyone. Health economics are important because whatever way you do it, if you're going to cost a lot of money, you'll be put aside a bit unless there's clear political gain. If it's so getting the outcomes that are going to be beneficial, and almost all advances are actually beneficial because they're more efficient, and people go back to work, people pay taxes, or the stay in hospitals less and all that. So even if the actual treatment seems more expensive, the longer term, the bigger picture is cost effective. So health economics, that's one of the things we really like to promote. We'd be very happy to have people work with us in doing that.
Thank you, sir. Dr. Srivastav or Dr. Raghav, any?
I think Dr. Chabra, this is one of the, thank you, Dr. Chabra. And, this is one of the very interesting presidential orations, and it's very important for youngsters what Doug Brown is saying, that we need to take every research with a pinch of salt, especially for youngsters, not to get carried away with developments, and especially the spinal cord injury, which is not in the, in the first, is somewhat neglected, or it's in the background of the doctors, spine surgeons' minds. They should start taking active interest in this. And you have been an active campaigner for this in India. And I thank you for this excellent presidential oration. Really, I think we should get into this spine research hub, see what's happening, the youngsters. And of course, pioneers like you in India, they should collaborate and get information from you how to proceed in this direction as well, which I think is somewhat neglected or in the background of the average spine surgeon's mind. Thank you, Dr. Chabra, for this excellent presidential oration, guest oration, I should say.
I would also like to congratulate Dr. Chabra for getting Dr. Brown to give this oration, full of wisdom and full of application for youngsters. And thank you, Dr. Brown. We will be all very interested in the spinal cord hub research. There are a lot of us who are doing some research on this, and it will be great to have your guidance and collaboration on this. Thank you, Chabra, for getting Dr. Brown.
Thank you, sir. VTI sir is not there. I think we are running out of time, but I would want to once again thank Dr. Douglas Brown for this wonderful presentation, and we will look forward to your continued guidance on how to carry spinal cord injury research further in this subcontinent. And of course, we will spread information about the work that you have been doing amongst all members. We have a small token ceremony to present the Oration Award to you. Of course, we can't present you in person. It will reach you soon, but there is a small ceremony, and please feel free to continue with listening to what would be on somewhat similar lines, the talk that I give subsequently. Thank you, sir. Please.
Thank you very much.
Ceremony, please.
Sushil, please play the video.
Thank you. I'm the Executive Director of the Spinal Research Institute. The Institute is dependent upon volunteers for its successful operation, and I'd like to take the opportunity to thank them.
So it's on its way and will be reaching you soon, the Oration Memento. Thank you once again for sparing time to be with us, to encourage especially the young members of the society, and we'll carry your word across to them. Thank you.
Thank you very much.
Yeah. Thank you all for such a wonderful session. Thank you, Dr. Douglas Brown. It was such a eye-opening lecture. We move on to the next session, which will be our presidential oration. I call upon Dr. Shankaracharya and Dr. Ramchadar to chair this session, please.
Can we share the initial slides, Sushil? Before Dr. Ramchadar introduces Dr. Chabra, President, I wanted to make a few announcements. I wanted to remind our viewers about the special session which starts at 4 p.m. in the evening today. It is going to be a grand evening today. We have to start with a joint meeting with the German Spine Society. Then we have a Spine 20 meeting which talks about the future of spine surgery, which explores newer techniques, technology, which will dominate spinal problems, spinal treatment, as well as surgery over the next 15 to 20 years. Very interesting. And the end of it will be the session on legends in spine surgery, where we will be interviewing legends, Dr. Stefano Boriani, Dr. Michael Failings, and Dr. Atul Goel and Vinod Lahiri. So please join us this evening for a very exciting academic talks. And now I hand over the mic to Dr. Ramchadda and our President-elect, Dr. Shankaracharya.
Good morning, everyone, and thank you, Gautam, and thank you, Appaji. I think we have a very important session now. That's the presidential guest oration, and our speaker is none other than Dr. Chabra, and I understand he's also going to talk on translation of spinal cord research to clinical practice. Why the long delay? We've just heard a talk similar, but we will hear from Dr. Chabra, our homegrown researcher who has done a lot of work in spinal cord society and in spinal cord research, as to how we can take this forward and what is the message from our president. Thank you. Can I ask Dr. Ram to introduce Chabra now?
Good morning, friends. I welcome you all for the ASSI presidential oration. May I take you back to the first scientific meeting of the ASSI, which was held in Mumbai between the 1st and 3rd of May 1986. This was the first ASSICON at the Vigyan Bhavan. We then had about 82 orthopedic surgeons and neurosurgeons, and the membership of the ASSI was 54. The theme was disorders of the lumbar spine. During this meeting, Dr. Ingalalekar interacted with many orthopedic surgeons from various parts of the country. They agreed that spine care and scientific deliberations were inadequately done all over. Dr. Baudekar, Dr. Dholakia, Dr. Chaubal, and Dr. Ingalalekar were instrumental in forming the Association of Spine Surgeons. In September 1985, Dr. Dholakia hosted a meeting which was attended by Dr. Chaubal, Dr. Baudekar, and Dr. Ingalalekar. Then the decision was taken to form the ASSI, or the Association of Spine Surgeons of India. We've had a large number of presidents, and we have still with us many past presidents: Dr. P.K. Dave, Dr. V.T. Ingalalekar, Dr. S.M. Hardikar, Dr. Shekhar Bhojraj, Dr. Arvind Jaiswal, Dr. S. Rajasekaran, Dr. Sajan Hegde, Dr. Raghavdat Mulukutla, and yours truly, Ram Chadda. It is indeed a matter of immense pride and privilege to introduce our president in the company of our president-elect. Our president, Dr. H.S. Chhabra, will hand over the reins to Dr. Shankar Acharya soon. He is the president of our association. He is the immediate past president of the ISCOS, chief of spine service and medical director at the ISIC, Indian Spinal Injury Center, executive member of the ASSICON and International Group of Advancements in Spinal Sciences, IGAS, member of the advisory committee of the stem cell expert group of the ICMR. He is also a part of the CDSCO, Institution of the Physically Handicapped Rehab Council of India. He is also part of the TAG, or the Technical Advisory Group, Ministry of Social Justice and Empowerment. He is editorial board member of Spinal Cord Journal. He is going to be speaking on something close to his heart: minimalism but comprehensiveness in spine care. Are we giving adequate emphasis? Dr. Chhabra has evolved to a situation where he was originally a protege in the hands of people who taught him. Then he became a peer, and I am proud to be one of them with him. He has then been a mentor and is mentoring people all over. He's hands-on in training probably the largest group of spine surgeons in our country. He's also a role model. He stands above all, and we look up to him to give us direction even if we can't reach him. But beyond these four levels, Dr. Chhabra has become a visionary who has published more than 100 papers, more than 24 full-length chapters. He's been awarded the ASSICON Star of 2018 by the Asian Spinal Cord Network. He is probably our man who has been honored by Dr. J.P. Nadda, Union Health Minister, for an immense contribution in the realm of medicine and growth of institution on 27th of April 2018. He got the ISCOS Society Medal Award 2013. He's got the Order of Star of the Italian Solidarity Award by the President of the Italian Republic, Italian Deputy Prime Minister and Minister of Foreign Affairs in 2007. He has been the proud recipient of the ASSI Clinical Research Award for 6 years. He's won the ASSI Basic Science Award thrice. What else can we say about the man whom we can only look as the future, the visionary, the man who is with us today to share what he knows best and is closest to his heart? May I welcome, with folded hands, our president, Dr. H.S. Chabra. Chabra ji, it's all yours and we are all yours. Thank you very much. Please go ahead.
Thank you, Dr. Ram Chadda, for that very kind introduction. I don't deserve all those words. Actually, it is teamwork, and we are very proud and happy to have a wonderful team here at ISIC and in India overall. As you mentioned, I will be talking on the topic on minimalism and comprehensiveness in spine care. Are we giving adequate emphasis? This will be the agenda of my talk, and I'll take you through this in my talk. Minimalism is the concept of focusing on the most essential things in order to provide greater fulfillment. In minimalism, excess belongings, distractions, things to do, and time commitments are whittled down to only those providing true value, while eliminating things providing mediocre or superficial value. Comprehensiveness is the state or condition of including all or nearly all elements or aspects of something. When it comes to spine care, specifically, it is providing for the full range of personal health services for diagnosis, treatment, follow-up, and rehabilitation. Briefly looking into the history of minimalism, how this movement happened, starting in 1800s, introducing simple living in America with the view that insight and enlightenment can be gained through solitude and simplicity. And then there have been various phases: the elevated design era, the minimalistic expansion, the adaptation of simple living, where they believe that the quality is preferred over quantity, and adjusting your life to a more deliberate pace will help you get the most out of it. To the present, where minimalism has become mainstream with the slogan, less is more. When it comes to spine care, it has become increasingly recognized in the spine field that the less treatment that is done to the patient and the more the patient is trained to provide self-care strategies, the better the outcome. The physician requires skill in decision-making regarding when, what, and how much direct treatment is needed in each patient, and equally important, when no treatment is necessary. Minimalism involves shifting the default setting away from interventions and towards conservative approaches such as watchful waiting and patient reassurance. In addition, minimalism is a key component of high-value care. It is an approach that focuses on education regarding the natural history of spinal diseases, maximizes patient empowerment, and minimizes practitioner-driven intervention. It allows the practitioner to focus on the value of care, which would not only benefit patients, but also the healthcare system and society as a whole by helping control costs while expediting early return to a productive life. This approach will also minimize the growing problems in spine care of patient dependency, whether on pharmaceuticals, interventional procedures, passive modalities, or other practitioner-provided services. And it is along the lines of historical ethical mantra of medicine, primum non nocere. First, do no harm. Second, relieve suffering. And third, contain cost. So, I will now be talking about the principles as applied in spine care and citing specific cases from the practice which reinforce this. First is reduce unnecessary investigations. Promoting good stewardship in clinical practice was an initiative of the National Physician Alliance, which developed a list of top 5 activities in primary care for which changes in practice could lead to higher quality care and better use of finite clinical resources. And one of these top 5 recommendations was don't do imaging for low back pain within the first 6 weeks unless red flags are present. There is enough published data also which documents the harms associated with early imaging for low back pain, including patient labeling, unneeded follow-up tests for incidental findings, irradiation exposure, unnecessary surgery, and significant cost. In fact, the award-winning paper today for the Young Scientist Award also delved on this important approach. We are all aware in spine trauma about the judicious use of diagnostic evaluation and the need for following a radiological protocol while evaluating. And this has been amply demonstrated by the Canadian C-spine rule and by the nexus criteria, as we are all aware about. When it comes to tuberculosis, the paper by Dr. Shekhar Abhojraj and Abhay Nene talked about very excellent results with empirical ATT, where a biopsy was not required for every patient of POTS. This was also the outcome of our recently concluded ASSI multicentric study, which was funded by AO Spine Asia Pacific, which also had the same outcomes and demonstrated the same results. The next important principle, skills in decision making. Recognizing when no treatment is required. How often do we face this situation in our outpatient clinics? We know that no treatment is required when there are no signs or symptoms, and findings on radiological evaluation don't need any treatment unless there are any sinister findings when further evaluation is warranted. But very often you get patients like this, when this patient who was given an MRI screening whole spine for neck pain, but then advised surgery elsewhere for a prolapsed intervertebral disc L5S1, where there was no history of lower back pain or radiculopathy. Similarly, this case of LCS who had sacroiliac joint pain and advised surgery elsewhere, but when we told them that they didn't need surgery, they were overwhelmed. How often do we get such patients of light spondylolisthesis with no signs or symptoms and good sagittal balance who have been advised surgery where it is not required? This post-traumatic syringomyelia with no signs or symptoms and no compression advised the surgery elsewhere. The next principle is giving an appropriate conservative trial unless contraindicated. So watchful waiting, and then surgical management option to be explored if there is failure of conservative management or any red flags. This patient of massive disc prolapse advised the surgery elsewhere, responded to our conservative treatment, and you can see the auto-absorption of sequestrated disc fragment. The case of spinal canal stenosis, similarly, degenerative listhesis grade 1, this lytic listhesis who responded to a facet injection, and also this degenerative scoliosis which responded to transforaminal epidural steroids and neurotropics. Osteoporotic vertebral compression fracture, responding to a conservative treatment. Central cord syndrome, where we did a watchful neglect and the patient responded to conservative treatment. Similarly, what you would call as an unstable burst fracture also responds very often to a conservative treatment in our practice. And this significant epidural collection at T8-9, which responded to conservative treatment. In fact, these are there in our practice, and very often people come to me because they have heard that very often patients respond to a conservative treatment. And a not very good reputation for a spine surgeon, when I sometimes advise them a surgery, they say, Dr. Saab, agar surgery karwani thi to aapke paas kyun aate? Not a good reputation, but ethics is what needs to be the prime consideration. We know that disc prolapse, the first line of treatment should be conservative. Similarly, Also, this was demonstrated in a study that we did, which is under publication. Massive disc prolapse also responds well to a conservative treatment. There's enough documentation. So does lumbar spinal stenosis, degenerative spondylolisthesis, ischemic spondylolisthesis, unless it is high grade. And also, this study revealed better pain relief, in fact, in the conservative group than in the surgical group for spondylolisthesis. Even adult ischemic spondylolisthesis will improve well with non-surgical management. A degenerative lumbar scoliosis very often do well with conservative management, and of course osteoporotic compression fractures, very often you see them coincidentally in an X-ray done for some other indication that the patient had some vertebral compression. Similarly, enough studies to show that there is no advantage with early surgery in ATCCS and that watchful neglect can be done. Similarly, thoracolumbar burst fractures, and as mentioned earlier, even unstable burst fractures can be managed conservatively. We are publishing our algorithms for cervical spine trauma and also thoracolumbar trauma, and most of them, except a few like flexion distraction injuries, have a clear-cut role under definite indications for conservative treatment also, as you can see here. The middle path regime, which was advocated by none other than Dr. Tully, was widely accepted and practiced, as also demonstrated by this publication by Dr. Rajashekharan and Ajay Prasad Shetty. There are many other papers which document this. Then, if you need a surgery, an appropriate choice of surgery with minimum intervention and tissue trauma. Minimally invasive spine surgery is in fact based on this principle, and this is the reason why it is becoming increasingly popular. Degenerative scoliosis also, you can do good minimally invasive spine surgery. Again, studies show that simple discectomy is better for massive lumbar disc herniation because the incidence of complications become less. So two scenarios here, a massive disc prolapse managed very well by simple discectomy. So what is the need for going in for a TLIF procedure unless there are definite indications for that? Similarly, recurrent lumbar disc herniation, very often a simple discectomy would do, and this is amply well documented in the literature. Decompression alone versus decompression plus fusion for lumbar spinal stenosis. I would never, hardly ever do a fixation for a lumbar canal stenosis unless there is clear-cut instability, that which is very rare. Decompression without stabilization in degenerative spondylolisthesis. Most of them are low grade and very often they respond, but you could use important principles like over-the-top decompression and sparing the midline. Short segment fixation in spine trauma is not only that it gives equal results as long-term fixation, it is better, especially for people with complete neurological deficit, because it spares rotation at that level, which is very important for a patient on a wheelchair, for him to become independent. And with a long-term fixation, you can cause more problems for the patient than doing a short-term fixation, and this shows good results. Hardly on the basis of 30 to 40 patients came the Gaines criteria, and we have been all following that. Now there is enough evidence that even with a load-sharing classification score of more than 7, properly chosen patients can do well without anterior augmentation also. You require circumferential stabilization only under a few definite indications for cervical spine trauma, junctional injuries, those requiring a corpectomy, or those with a lateral mass fracture, and most others will do well with either a posterior or an anterior fixation. So more why and less how. The shift towards value-based spine care requires appropriately designed and executed studies to define treatments that are most effective at the lowest cost to both the patient and the healthcare system. Now coming to this important principle, first do no harm. We know that before any investigational product is introduced into the market for human use, it should be backed by ample preclinical and clinical trials demonstrating its feasibility, safety, and efficacy. Despite that, stem cell transplantation for human SCI has been introduced into clinical practice. It is unethical to do so, and there have been various claims by people, and the undue hype by the media does a profound psychological damage to the spinal cord injured and interferes in the rehabilitation process. Minimalism doesn't mean compromise on comprehensiveness. If we ignore comprehensive management, doesn't it amount to neglect? For example, treating osteoporotic fracture but not the osteoporosis. When we know that a single vertebral fracture would be associated with a multi times increased risk of major osteoporotic fractures subsequently. Despite that, there are studies which show that a vast majority, up to 85% of them, are not prescribed management of osteoporosis, and just the fracture is managed. A pediatric spinal deformity needs overall comprehensive management to build up the patient before the surgery so that the patient can take that well. How many times do we do that? A comprehensive oncology care for these oncological patients. And very often people manage the back pain but do not look into prevention of recurrence. Do not counsel regarding removal of predisposing factors so that recurrence doesn't happen. And here I would want to enumerate our study that I was talking about, which looked into lumbar prolapse intervertebral disc with our multimodal conservative therapy, and only patients who would not respond would go to transfemoral epidural steroid and surgery if indicated. Out of the 403 patients included in that study, only 22 got operated, and the vast majority responded to a good conservative treatment with good outcomes for back pain, radiating pain, patient satisfaction, and functional outcome, which were comparative or better than any of the long-term trials documented so far. Only 5.4% required a surgery, better outcomes than most of the long-term studies done so far. And more importantly, among the sample size of 433 patients, 69% or 277 had been advised surgery elsewhere by other physicians. At 1 year follow-up, only 18 or 6.5% of them required surgery. So does that only makes us wonder, are we giving more emphasis on surgery than on comprehensive conservative management? We know that persons with SCI are a vulnerable population, and that surgical or conservative management of the vertebral lesion is just one component of comprehensive management of SCI. They need a multidisciplinary comprehensive management. And studies have documented better outcomes for patients on whom rehabilitation is initiated early, especially in an organized multidisciplinary spinal cord injury care system. And this has led to the saying that life after a spinal cord injury can be happy, meaningful, and worth living. And this is not only, this is a belief, and people have amply demonstrated that. However, our study showed that more than 25% of the patients report to us after 1 month of the injury. Very often, due emphasis is not given on comprehensive management. We define neglected traumatic spinal cord injuries as injuries in which comprehensive management is not initiated in a timely fashion. A total of 83% of patients had been sent back or had gone home after only a component of management had been initiated. So the causes that we found of neglect was in fact inadequate or lack of awareness in the vast majority, 53%. Financial constraints, as you would expect, were way behind with 25% of the cause. And this we know leads to a compromised outcome of vertebral lesion and rehabilitation, leading to increased incidence and severity of complications, longer hospital stay, and higher costs of hospitalization. Our study brought out that spinal cord injury in India and Asian spinal cord network region face numerous challenges that affect access to almost all aspects of comprehensive management of spinal cord injury. This other study also showed that most of the patients were sent back home after acute management. There is a lack of trained professionals and non-availability of multidisciplinary team, leading to various aspects of comprehensive care being neglected in these patients. This is an example of a patient who got an injury in the heels due to a fall, and only after 3 years he came to our center and saw the light of the wheelchair after 3 years, as he said. And then, with a good comprehensive management, he came back not only to an active lifestyle, he's mentoring patients. Initial phases of his rehabilitation to a comprehensive rehabilitation where he moves around now in the hills where he has gone back to with his parents. So, coming to the question, is ASSI giving appropriate emphasis on minimalism and comprehensiveness? I look into the scientific programs of some of our previous conferences show that we have only 2% of the papers very often covering conservative treatment. And this increased to 8 in some of the meetings, but is that adequate emphasis? What can ASSI do to give appropriate emphasis on minimalism and comprehensiveness? We can give adequate emphasis in scientific activities, as we talked about, adequate emphasis in educational activities, in the webinars, instructional courses, fellowship curriculum and training programs. We can create awareness of the various educational resources. We can give adequate emphasis on advocacy activities, liaise with and sensitize the policymakers to create adequate infrastructure, human resource development, emphasis on prevention and legislation. There are various solutions which are there even in a country like India for spinal cord injury management, like creating a pyramidal network of spinal cord injury centers, and only a small SCI unit on all medical colleges and hospitals having a department of PMR would do the job. Legislations are required on unethical practices like this. And in fact, these are just some thoughts. It could be taken forward by an ASSI task force on minimalism. In the end, does the name convey the intent? Our name is the Association of Spine Surgeons of India. Does it imply that we do not advocate comprehensive care or conservative care to the patients? A look into all the names of the other societies across the globe reveals only 4 societies which may have surgical in their name. So that makes us wonder, is the name Association of Spine Surgeons of India appropriate, or should it be Indian Spine Society or Spine Society of India? I conclude my talk with this food for thought for all of you. Thank you.
Thank you, Dr. Chabra, for this wonderful talk. Actually, you have raised so many important issues, right from the name of the association. And I think it's a very relevant point when you highlight the fact that there are only 4 associations with surgeon's name in it. The concept of minimalism you introduced is very important. And when you showed the slide in which only 2% of people have produced papers on conservative care, even I was surprised. I think Dr. Chabra has highlighted the importance of good ethical practice. And as the award paper, which was from the Ganga Hospital, which showed that how patients get psyched because osteoporosis, disc prolapse, port spine, degenerative lumbar listhesis, lumbar canal stenosis, these are the common things we get. And a lot of them can be actually treated conservatively. Most of the patients in today's days have done multiple shopping, they've gone to different places, and we tend to ignore the full history, go on to the investigations, and then go on for treatment. I think there are a lot of people listening, and it's a message for us as well as for the youngsters who are getting initiated into practice, because as we grow more and more, it should not be like always operate on spine surgery cases, or always operate indications which we see on X-rays and MR. I think it's very, very relevant what you said. And I thank you for this excellent presentation. It's fantastic. Thank you, Chabra.
Thank you, sir.
Chabraji, that was fantastic. We really appreciate the vision that you've shared with us. And I strongly believe that I was not wrong, that you are the visionary showing us the way forward. Thank you. Stay healthy, stay happy, and be a part of the association. By whatever name you may call it, it's going to be the best. God bless you.
Yeah, Chabra, outstanding, Chabra. That was really fantastic. I think a message that truly should come from the president to everybody. Yeah.
Dr. Chabra, I feel proud to be associated with you because you have comprehensively thinking of spine. People get orgasm by seeing postoperative X-rays with 20 screws and total 30 inches of rod length. And they discuss with each other that in the month of December, I use 11 kilograms of metal. I think we need to look at the whole thing in a very correct perspective. And thank you once again for bringing out. Irrespective of what the name is, and if the surgeons practice non-surgical part, the name need not be changed. It's the mindset which needs to be changed.
Exactly.
Thank you very much, Dr.
Chabra.
I thank
Chabra, if we had all met face to face.
Morning, listen and have.
Gautam, Dr. Raja wants to speak something.
Okay, we are running.
No, just one single sentence that Chabra, if we had had a face-to-face meeting, you would have got a standing ovation. But I think mentally we are all very much accelerated with your fantastic talk. Thank you very much for bringing in this concept.
Thank you again, Dr. Chabra. As you have heard, each and every one of the past presidents has given accolades, and whilst in a personal meeting, you would have got an award, a presidential shawl, and a medal. Unfortunately, we cannot do that, but I would suggest that Nima, who is in your office, can deliver it to you today itself. You doesn't have to wait for a week. Sir, hats off to you for your fantastic work. And I thank you for this talk. And on behalf of all the members of the Association of Spinal Surgeons of India, I thank you not only for this talk, but for this fantastic vision that you have shared as a president of the Association of Spinal Surgeons of India over the last 2 to 3 years. Sir, we require your guidance. And as past president, we hope you'll be continuing to get involved with association activities with the same vigor and guide us, help us to think more, think bigger, and think better. With these words, I bring the morning session to a close. I thank Dr. Shankaracharya, Dr. Ram Chadda for chairing this session. And I thank all the eminent people on the link, on the Zoom link here, who have spent the morning and in order to encourage youngsters like us to progress and think more and better and out of the box for our patients.
Thank you, Gautam.
Announcement for all of you. The general body meeting of the Association of Spinal Surgeons of India is beginning within the next 15 minutes at 11:30 a.m. And it will be through a separate link. The link has been sent to you by email. The link is a specific link for you. Nobody else can log in through that link. So please log in through that link. You will not be able to join the meeting through this current link. Thank you very much and good day. Looking forward to seeing all of you in the evening too.
Thank you all for such a lovely session. Thanks, Gautam, for the opportunity. Thank you, sir. Chabra, sir. We are always at your service. Yes, thank you all. See you at the GBN.
Dr. Chahal for moderating this session so beautifully and keeping it to time. Thank you very much. Or ahead of time, I can say.
Thank you very much, everyone. Just a small note that Gautam, you don't qualify to be young anymore.
On what?
He just called himself young.
You can't qualify to call yourself young anymore.
I am at least 5 years junior to you, Shankar. At least.
See you then.
Sir, the link is from ASSI Secretariat.